Welcome everyone to this webinar presented by ISOPAB on high risk pregnancy. To take this session ahead, I would like to introduce our two conveners for today evening, that is Dr. Amita Sinha and Dr. Ranjana Sinha. Dr. Amita Sinha currently is the Joint Secretary TOGS, Vice President ISOPAB Patna Chapter, Governing Council Member of IFS Bihar Chapter, Member Young Talent Promotion Committee FOXY, and Member Clinical Research Committee FOXY. She has many awards and also she is the life member for IMA, FOXY, FIGO, ISOPAB, FAOPS, Indian Fertility Society and ESAR. Welcome Dr. Amita Sinha ma'am.
Thank you.
Our next convener for today is Dr. Ranjana Sinha. Madam is currently the consultant at Gynae Clinic Patna. She is the Joint Secretary ISOPAB, also co-chairperson Quiz Committee and Executive Committee member ISOPAB Patna Chapter. Ma'am is also Executive Committee member IFS Patna Chapter and life member to Foxy, FIGO, ISOPAB, IFS, IMA. She is the recipient of National Award for Outstanding Service in Indian Railways at 2014. Welcome Dr. Ranjana Sinha ma'am. Over to you.
Thank you, Sana. Respected ISOPAVians and dear attendees, a very good evening to all of you. Dr. Ranjana Sinha and I, Dr. Amita Sinha, coordinator of today's webinar, welcome you to this program on high-risk pregnancy. We are fortunate to have Dr. Kamal Bakshi Madam as a chief guest with us to grace this occasion. Apart from this, we have three guest faculties, Dr. Vatsara Dhadwal from Delhi, Dr. Vijay Lakshmi Seshadri from Chennai, and Dr. Shobhana Mohandas from Thrissur. Topic for discussion is related to isoimmunized pregnancy, RH isoimmunization. As we all know that ISOPAB is the educational society where pediatricians are major contributor and participant. So today we have also a talk by pediatrician related to isoimmunized baby, management of isoimmunized baby. And Dr. Vijay Lakshmi Seshadri is going to speak on VVAC, vaginal birth after cesarean section. Hope you all will enjoy this academic feast and definitely you will be benefited. So without further delay, I would request our President, Dr. Usha Sharma Madam, to kindly give welcome address. Madam, please. Sana, can we have the CV of Dr. Usha Sharma? Sana?
Yes, it is on the screen.
And it's
Yes,
already
it is on the
displayed.
Okay. Dr. Usha Sharma Madam is National President ISOPAB 2020-2022. She is Consultant Obstetrician and Gynecologist at SK Memorial Hospital and AK Memorial Nursing Home, Patna. She is Honorary Consultant at Red Cross Polyclinic, Patna. Advisor, Safe Motherhood Committee, Patna OBGY Society. Madam has presented many papers all over India in FOXY, ISOPAB, RCOG and other societies. And also she contributed many chapters in FOXY publications. She is also former East Zone Fellow Representative of RCOG and former Vice President and Secretary General ISOPAB. Madam, over to you.
Good evening to all of you. Good evening to all of you. First of all, greetings from ISOPAB for joining this webinar. I welcome you all to this webinar on ISOPAB platform. The theme today is high-risk pregnancy, and the topics to be covered are isoimmunized pregnancy management, current trends, and management of the neonate. The other topic to be covered is vaginal birth after cesarean delivery. Another point I would like to make, or rather a request, that tomorrow and day after tomorrow, Matrika, a society, city chapter society in ISOPAB, which is very active, has got a 2-day webinar from 4 p.m. to 7 p.m. Their theme is preventive perinatology. I can assure you, if once you join the webinar, you will find their scientific standard is of very high standard. There is also another announcement by me which has been requested by Brahma Kumaris that I mention it to you people, that 3D antenatal care, by which they mean a holistic approach to pregnancy in which they intend to make pregnancy a stress free situation. They are going to conduct a series of webinars starting from 13th December onward. It will be a weekly program on Saturdays in the evenings and on Sundays midday. Timings you can check on their website. And this will go until 28th February. And this will be very beneficial for expectant mothers, their families, gynecologists, and people involved in antenatal care. So I request you that in your spare time, as per your convenience, do join and see what they have to offer in this holistic approach to pregnancy. Now, I will request the two conveners to conduct the scientific program.
Thank you, madam. Now I request Dr. Ranjana Sinha to introduce chief guest, Dr. Kamal Bakshi, madam.
Good evening, respected dignitaries and dear colleagues. Dennis Watley said, all the top achievers I know are lifelong learners, looking for new skills, insights, and ideas. Dr. Kamal Bakshi, our chief guest today, has been such an achiever all through her life, and it is really a lifetime honor for me to read out her CV today. Reaching to all the topmost positions in prestigious institutions and organizations, it is her kind attitude and academic passion which has brought her here today amongst us. As all of you know, Madam Bakshi is former professor and head of the Department of Obs and Gynae, AIMS, New Delhi. She is medical director, the Women Clinic, Noida. She is senior consultant Obs and Gynae, Indraprasth Apollo Hospital and Fortis La Femme. And she has been former president of the prestigious FOGC and ISOPARB societies. She has a number of awards, all the topmost awards of the gynecological and medical field, like Dr. B.C. Roy National Award. She has received Lifetime Achievement Award from many organizations like FOGC, ISSRF, LOGS, AIMS, and ISAR Delhi chapter. She has been bestowed with Women of the Year Award in 1998, Bharat Jyoti Award, Indo-Norwegian Scientist Award. She has been given a Living Legend title by Gyneplastic Surgery Society of India, and in her name there is an oration, Kamal Bakshi Oration, instituted in recognition of her pioneering work in fetal medicine. She has also been bestowed upon with Dr. APJ Kalam's Living Legend Award. She has more than 250 publications in national and international journals, and she has many first times in her name across the world and in India. She has successfully performed ultrasound-guided fetal skin biopsy in 1988 for the first time and standardized the technique to detect fetal skin disorders. In India, she successfully performed intrauterine fetal blood transfusion way back in 1986, uterine balloon therapy, and started the unit of fetal medicine at AIMS. With such an stalwart amongst us as our chief guest, we are really honored. Madam, please bless the august audience today. Madam Kamal Bakshi, please. Madam, please unmute. Madam, please unmute yourself.
Good evening. Can you hear me?
Yes, ma'am.
Yes, ma'am.
Good evening, my dear friends and colleagues. President Dr. Usha Sharma ji, distinguished past president, vice president, convener, chairperson, secretary general, Dr. Meena Samat, and my old friends, I am pleased and honored, humbled and speechless by the amount of love, respect and regards given by each and everybody, the family of ISOPAV. It is one of the oldest society and an excellent society which combines not only the mother, the neonates also, a very holistic approach. And I remember the days, my good friend, Dr. Kamla Acharya ji, Dr. Jagdishwari Mishra, and so many, Dr. Tripathi, Milan, Dr. Chatterjee. You all, the leaders, and look at our stalwart, Dr. Usha ji, and what a nice theme of the year that has been chosen. I am today the student of yours, and I would like to hear about this high risk pregnancy, which is one of the most important aspects. And even I must say, this Matrika, such beautiful topics, and I would say it is the need of the hour, the repetition that is required, just like our sweet Dr. Arul has been a great friend, and so is the ISOPAP, the best friend that I have possessed, and I have the fondest memories. And I'm looking forward now, without wasting more time, to listen what our lovely speakers and one of my students, Dr. Vatsala, then about the immunized pregnancy, the babies, how they are going to manage, and this excellent topic, the vaginal birth after cesarean section, the challenge which the obstetricians and the neonates are taking for lowering the maternal mortality and the morbidity, as well as the fetal and the neonatal. And thank you for your kind invitation once more. My pranam to all of you.
Thank you, ma'am, for your blessings. Without wasting any time, I think we should move on to our first scientific session. And for this session, I would like to invite two eminent personalities, one from the field of gynecology and another from pediatrics. And I am very happy that they both belong to Patna, and they have national figures in both ISOPARB and FOXY. So first of all, I would like to invite Professor Nigam Prakash Narayan sir. He is retired professor and HOD Department of Pediatrics, Patna Medical College. At present, he is Director, Newborn and Child Health Care Center, Patna. His major achievements are: he has been member governing body NNF twice, member executive committee IAP twice, and at present, he holds the post of Vice President East Zone CIAP 2020. He has many awards and honors, publications, and other prestigious things. And he has received awards from FIAP, FNNF, FRCP, CHUK, FPAI, and he has several national and international publications. Sir, I invite you to this virtual platform to conduct this session. And further, I would like to invite Dr. Pragya Mishra Chaudhary, who is a very good friend of mine, and all of you know her. She is a treasurer. She is treasurer ISOPAP, and also she is consultant infertility specialist at New Life Test Tube Baby Center and MGM Hospital and Research Center, Patna. She has a special interest in genetics and fetal medicine. Also, she imparts FOXY certified colposcopy training. She is immediate past chairperson, Genetic and Fetal Medicine Committee, FOXY, and she has been founder secretary of Bihar chapter of ISOPAB. As all of you know, she is treasurer National ISOPAB from 2017 until date. She is currently secretary Patna Obs and Gynae Society 2019-2020, and she has been awarded with many awards: Healthcare Professional of the Year 2018, George Mahoney Award 2014 by RCOG, Dr. C.L. Jhaveri Award, Dr. J. Mishra Gold Medal, Dr. M.P. John Gold Medal, and she has contributed many chapters in books and papers in national journals. And she has been organizing secretary of BoxCon as well as Foxy Ispat GFM Con 2018 Patna. So I request Dr. Pragya Mishra Chaudhary also to come to the virtual platform and conduct this session. So now I hand over the session to Professor N.P. Narayan sir and Dr. Pragya Mishra Chaudhary.
Yeah, and thank you very much, Dr. Ranjana. I'm really thrilled, I'm really very much impressed by the both conveners, how beautifully they have actually conducted the whole session. And I actually am grateful to the ISOPARB who have given me this opportunity to be with you, my friends of ISOPAL, and especially Dr. Usha Sharma, our president of ISOPAL, Bihar ISOPAL, and of course the past president, Dr. Kamal Bakshi, who has been a pioneer in your field. She has graced the occasion with her presence and such a nice blessing. So I think with these words, I think I'll not like to introduce my speaker, Dr. Rakesh, right now, because I think the first speaker is from the obstetrics. So I'll request Dr. Pragya Mishra to introduce the first speaker, please.
Yeah. Thank you, Dr. Narayan. And thank you so much, Ranjana, for such an elaborate introduction of mine that you gave. And very nice to see Dr. Kamal Bakshi, seeing her after a long time. And Ushadi and Meena and all the other office bearers of ISOPA. It's indeed a pleasure and a privilege to have to actually chair a session which is being for which the speakers are Vatsala Dhadwal and Dr. Rakesh Kumar, both stalwarts in the field. And in fact, Vatsala was a member of my genetics and fetal medicine committee when I was the chairperson. I think you remember Vatsala.
Hello. Yes, Dr. Pragya.
Hello.
Yes, Dr. Pragya.
Yeah. No, I thought, because I'm in the hospital, so I was wondering whether the network is good. So
I was muted.
So Vatsala is currently a professor, and she's the chief division of maternal fetal medicine, Department of Obstetrics and Gynecology, All India Institute of Medical Sciences, New Delhi. And Dr. Vatsala Dhadwal's area of interest are fetal medicine, diagnostic and therapeutic interventions, including intrauterine transfusions, then interventions in complicated monochorionic twin pregnancies, then lasers for twin-to-twin transfusion syndrome and fetal reduction. So we have a lot to learn from Vatsala, and she also has a special interest in 11 to 13 plus 6 week scan, anomaly scan, and high-risk pregnancy. Well, her major achievements have been that she has contributed lots and hundreds of papers in international and national journals, about 130 international and national publications and 50 presentations. And she has piloted and co-piloted in 15 international and national clinical studies. And she's a teacher for MBBS and MD students and fellowship program in maternal fetal. I just have to reduce the size because, And she is currently the nodal officer for prevention of parent-to-child PPTCT, which is Prevention of Parent-to-Child Transmission Program. She is the executive committee member of the Society of Fetal Medicine. That was in 2014 to 15. She has been the chairperson of AOGD Fetal Medicine Subcommittee 2017 to 19. And she is the secretary of Association of Obstetricians and Gynecologists of Delhi. And she has received many awards. And some of them are, one is the Young Researcher Award, which was conferred upon her by the International Clinical Epidemiology Network in 2002. And she was also conferred with the Rogham Foxy Award in 2008, and from ICMR, which was the International Senior Biomedical Scientist Fellowship Award in 2015. So, well, we have such a versatile, talented person in front of us, and who's going to deliver her talk on RH immunized pregnancy and its management. Now, RH, in spite of the fact that, on every platform we've been discussing about RH immunization, but it is a pity that still, immunization have been occurring, and still, inadvertently, the anti-D is being missed out. And, we are all here, with Vatsala to listen to her and, what we can do and how we can, manage these pregnancies once they've already been immunized. So over to you, Vatsala.
Thank you, Dr. Pragya, for your kind words. And it's my privilege to be here with Professor Bakshi. Madam is a pioneer in fetal medicine, and she was the one who started intrauterine transfusions. And I'm proud to say that we are continuing her legacy at AIMS. And my warm regards and thanks to Dr. Usha Sharma, President ISOPAV, and other office bearers, Dr. Meena Samant, Dr. Amita Sinha, Dr. Ranjana Sinha. Thank you all for inviting me in this webinar. And I'm just going to share my slides. So I'll be talking about management of pregnancy complicated by RHD aluminization. It is a disease which is to a large extent preventable because of the availability of anti-D. And it is also a disease which forgives you if you miss the anti-D, because if there is fetal anemia, you can do intrauterine transfusion. But nonetheless, it is better to prevent the disease than think of curing it. But what is the current scenario? Things have not changed over the years. This is the late data of the last 15 years from 2000 to 2015. And what we see, the number of women we are seeing with RH isoimmunized pregnancies is increasing. We are doing more and more transfusions every year. The only good thing is that the number of pregnancies referred with fetal hydrops has decreased. So we still have a long way to go. So with this as a background for some deep thinking as to what is happening and how we can sort of prevent this scenario, I would start my talk. And what is important, if you have a patient who's RH isoimmunized, please refer to a fetal medicine specialist in time so that she can be managed appropriately. Starting a little with the basic, when an RH negative mother is carrying a fetus who has RHD positive red blood cells, we know that fetal-maternal hemorrhage keeps occurring throughout pregnancy and it's maximum at the time of delivery. So the mother is exposed to the D antigen on the fetal RBCs. So during the first pregnancies, when the RBCs go into the maternal circulation, she mounts an antibody response, which is IgM type, which does not cross the placenta. So first pregnancy is not affected. In the second pregnancy, when the mother is subsequently exposed to D antigen, she mounts an immune response, which is IgG, which is more rapid. And this IgG can cross over to the fetal, cross the placenta into the fetal circulation, causing hemolysis and fetal anemia. And this IgG is detected in maternal blood by a test called indirect Coombs test. And then we say the mother is isoimmunized. So what happens is these antibodies which cross to the fetal circulation get attached to the RBCs, which are lysed, causing anemia, and there is hepatic erythropoiesis and dysfunction leading to hypertension, portal vein hypertension. There is heart failure because of anemia, leading to finally hydrops, fetal death. So we know that like throughout pregnancy, there is fetal maternal hemorrhage occurring, and even a volume as small as 0.1 ml can isoimmunize the mother. So the risk of isoimmunization after Rh negative positive pregnancy is 16% in ABO compatible fetus in the mother. If there is ABO incompatibility, this risk decreases because of ABO incompatibility, the cells are cleared from the circulation. So the mother is not exposed to the cells too long to mount an immune response. So the overall risk of sensitization is 13 to 14%. There are other events during pregnancy which can also lead to sensitization, like invasive procedures, prenatal diagnostic procedure, molar pregnancy, abortions, maternal blood transfusions, abdominal trauma. All these can lead to isoimmunization. And we know that prevention is very easy by giving anti-D. So anti-D should be given to all women who are Rh negative carrying a Rh positive baby after birth. So this 300, what is the standard dose that is available to us is 300 microgram, which can neutralize 30 ml of fetal blood or 15 ml of RBCs. Generally, the fetal maternal hemorrhage is not less than 4 ml. So this single dose is adequate to cover all the fetal maternal hemorrhage. So how do we manage a woman? Like, it is a mandatory that we should do a blood group and D-typing for all pregnant women coming to the antenatal clinic at the first visit. And if we find that if a blood group is Rh negative, we should do the husband's blood group. If the husband's blood group is negative and we're very sure of the paternity, then only we don't need to do an ICT. But otherwise, also, it is a good idea to do an indirect Coombs test to see if she's isoimmunized, even if the husband is Rh negative, because there may have been a previous concealed history of pregnancy with another partner. So if the woman is Rh negative and the husband's blood group is Rh positive, then we do the indirect Coombs test. If that is negative, that means she's not isoimmunized. So we do the ICT titers. You can do it either 4 weekly, or the more cost effective is to just do once at 28 weeks. If it is negative, give her anti-D. And then after the baby is born, then we do the blood group and the direct Coombs test. And then if the baby is Rh positive, then we give the anti-D postpartum. So we know that the D antigen is carried, like if it is husband is homozygous for D antigen, all the offsprings are going to be affected. If it is heterozygous, then 50% of the pregnancies are affected. Unfortunately, we don't have the test, or it's not easily available to look at the homozygosity or heterozygosity for D antigen for the husband, because that can, if we can do that, and if the husband is homozygous, we know all the babies are going to be affected. But if the father is heterozygous, and we know that 50% of the fetuses may not be affected, in the sense they may be Rh negative, only 50% would be Rh positive, we could do fetal Rh status by cell-free DNA in the maternal circulation, which is very sensitive. So this is being done in many of the countries abroad, but we are still not doing it, and maybe in future it may be an option for us. Because if the baby, if we know that the fetus is D negative, is Rh negative, then we don't have to sort of give anti-D antepartum or do intensive monitoring in case we're suspecting that the mother is isoimmunized. So all women who are D negative and ICT negative should be given anti-D. Women who are already isoimmunized should not be given anti-D. It is not going to help, and it is a waste of anti-D. And if the father is negative and we are sure of the paternity, we don't, and ICT is negative, we don't giving it. If the fetal red cell DNA test fetus is Rh negative, then we don't need to give antepartum anti-D. So antepartum anti-D we give at 28 weeks, a single dose of 300 micrograms, or you can give 2 doses, 100 micrograms at 28 and 32 weeks, and within 72 hours of delivery after checking the baby's blood group. So it is a polyclonal, or is available as polyclonal or monoclonal antibody. The problem with monoclonal antibodies may not cover all epitopes, so it may not be as effective as polyclonal. So once you give anti-D in the antenatal period and the postnatal period, you reduce the risk of sensitization from 16% to 0.2%. So it is very effective. So, but if you have forgotten to give the anti-D dose, you have not given adequate dose, or you have missed the antenatal dose, or there has been unrecognized fetal-maternal hemorrhage, or maybe the mother is sensitized to some other RBC antigen besides D antigen, then the failure would occur and the mother may become albuminized. So these are the certain conditions in which large fetal-maternal hemorrhage can occur, for which we can either do tests to look at the quantify by Kleher-Bethke or flow cytometry. If the facilities are not available, then maybe we can give 2 doses of anti-D. So what we need to understand is, once you give anti-D at 28 weeks, or if you're given anti-D earlier in pregnancy because she's had some threatened abortion or some bleeding, then anti-D weak titers, which are less than 1:4, may persist for several weeks. So this should not be misconstrued as the mother is albuminized and, refer her and sort of scare her that the baby is going to have problems. So this needs to be understood. And after delivery, if you omitted the dose, give it, even if it is within 13 days, even up to 3 to 4 weeks, give the dose. It may have some effect. It will prevent immunization. If the mother delivers within 3 weeks of the anti-D, then you don't need to repeat the dose. So any sensitizing event, whether it's a spontaneous abortion, surgical abortion, missed abortion, intermittent bleeding during pregnancy, ectopic pregnancy, or molar pregnancy, please give anti-D. Because D antigen is expressed on the fetal RBCs as early as 7 to 8 weeks. In the first trimester, the dose is 50 to 100 micrograms. After 12 weeks, it's 300 micrograms. If you don't have 100 microgram available, give 300 micrograms. It's not going to harm her. It will be protective. And in case of repeated episodes of bleeding, you may repeat every 6 weeks because the half-life is 6 weeks. So Dr. Deka et al. Had looked at the cause for failure, and they found that the women who are coming to us with isoimmunized pregnancy, at least 50% of them had received anti-D, still they had become sensitized.
अच्छा उनको रोकिए मैम.
How do we monitor or manage a woman who is coming to us with the first sensitized pregnancy? That is, this is the first time that her ICT titer has become positive. So usually the first pregnancy, the ICT titers are low, and the chances of the baby developing severe fetal anemia requiring intrauterine transfusion is very low, and it is usually in the latter half of the pregnancy. But we need to monitor the mother with indirect Coombs test every 2 weeks. As long as the titers are below the critical titer, we are not worried about the baby developing severe anemia. But once the titer, ICT titers cross the critical titer, which is specific to labs, for us it is like 1 in 16 or more, then we are going to worry, because once the critical titer is reached, the baby can develop severe fetal anemia and may require transfusion. So we start monitoring for fetal anemia, for which we use Doppler ultrasound of the middle cerebral artery. So once the woman comes to us and we do her ICT test and we find that she is isoimmunized, first of all, check the titer. Is it more than the critical titer? Does she have a previous history of affected baby, like the baby had anemia, jaundice at birth, there was hydropic, required intrauterine transfusion? If it says no, then we monitor the IC titers every 4 weeks till 28 weeks, and then every 2 weeks. If it does not reach the critical titer, we are not worried. The baby is not likely to be having severe anemia, and we deliver a term at 37 weeks. Anytime the titer crosses critical titer, or there is a previous history of affected child, we know that she is at a risk of developing fetal anemia, so we need to monitor, and then we monitor using Doppler. There may be a role, I said, like I talked earlier about doing paternal zygosity for the D antigen, whether the father is homozygous or heterozygous, by looking at the D antigen in cell-free DNA in the maternal circulation. Because if the baby is Rh negative, then we don't have to do such intensive monitoring, causing so much stress to the mother. But for us, this facility is not easily available, so we have to resort to monitoring all isoimmunized pregnancies for fetal anemia. If it's the first isoimmunized pregnancy, the prognosis is usually good. And in a series of 106 pregnancies, they found that 60% did not develop critical titers, 40% did. Of the women who developed critical titer, only 26% required intrauterine transfusion. And of those with critical titer, 50% of the babies had anemia or jaundice at birth. So even first isoimmunized pregnancy should not be taken lightly. There is risk of fetal anemia. So these pregnancies should also be managed at with the fetal medicine or high-risk pregnancy expert and in a center which had a nursery, because the baby may have anemia and jaundice at birth and require treatment, which would be covered in the next talk. What happens when she comes with the second, third, fourth immunized pregnancy? History is very important. We know that as the infection is more severe and occurs earlier in subsequent pregnancies, so there may be, initially there is usually a history of jaundice at birth, anemia requiring exchange transfusion. Then maybe and as the severity of the disease increases in subsequent pregnancy, there might be a hydropic baby. There may be a history of intrauterine transfusions. There may be a history of early neonatal death. So it's important to take the history because we have to be more careful in the subsequent pregnancy. It is not uncommon for us to see these kind of cases where you have a 9th or a 10th gravida with one living issue or no living issue and multiple losses because of this disease. So we have to monitor these women for fetal anemia. And now the gold standard for screening, we won't say diagnosis, it is screening, because diagnosis is when you definitely diagnose is by doing cord blood sample, when you actually do the hemoglobin. But for screening anemia is by ultrasound Doppler of the middle cerebral artery. And the advantage is there is no risk of fetal loss. It is not an invasive procedure and it does not exacerbate or fetal-maternal hemorrhage. So it doesn't exacerbate anemia. Invasive methods like amniocentesis are no longer done, and cordocentesis is only reserved when we are suspecting fetal anemia to confirm and do intrauterine transfusion at the same sitting. So earlier we were doing a lot of amniocentesis and we would start at least 10 weeks prior to the previous affected pregnancy. And we used to do the spectrophotometry of the amniotic fluid to look at the bilirubin levels. That was an indirect estimate of anemia and not a very correct estimate. And then plot the deviation at delta 415 wavelength. And that OD value deviation was plotted on the Lizzie's chart. And then we would say if it is upper part of zone 2 or 3, baby is likely to be affected. We should do Cordo plan for transfusions. And we would find that there was a high false positive rate. We would do a lot of procedures thinking the baby is anemic, and actually the baby would not be anemic. So that has, and what about ultrasound? There are a lot of ultrasound features which may be there in fetal anemia. But if the markers are absent, that doesn't rule out anemia. And the only ultrasound marker which can definitely say there is anemia is hydrops. And we definitely don't want to wait to that stage. So ultrasound is not very sensitive. What is good is the Doppler of middle cerebral artery, peak systolic velocity. If done in the proper technique, it has a very high predictive value for anemia. And why are we looking at this vessel? Because in response to anemia, there is increase in fetal blood velocity in various vessels due to increased cardiac output and decreased blood viscosity. And the most promising vessel is the middle cerebral artery. And in the earlier study, it was found that it was 100% sensitive, that 100% of the cases of anemia were picked up with only 12% false positive. But a recent meta-analysis has shown that it has a sensitivity of 86%, that it will pick up 86% of cases of anemia, 14% may still be missed. But still, it is the best test for detecting fetal anemia. And the values are dependent on the gestational age, so they're converted into multiple of medians. If the value of middle cerebral artery peak systolic velocity is 1.5 or more, then we know the baby may have moderate or severe anemia and we should plan for intrauterine transfusion. Just as a rule of thumb, if the value is twice the gestational age, the baby is likely to be anemic. So if you look at 24 and look here, 1.5 to 1.55 is twice, almost twice. So that is easy to know if instead of looking at the charts also, we can make out if the value is more than 1.5 or not. And usually we define fetal anemia if you broadly say any hematocrit less than 30%, but there are different ways of defining fetal anemia depending on the deviation from the median value of the hemoglobin, or it can also be expressed at multiples of medians. So how do we monitor? If it is a first ICU-immunized pregnancy, we can monitor them every 1 or 2 weeks. And if the titer is, if the MCA-PSV value is coming close to 1.5, then we monitor more frequently. But in women who had previous affected pregnancy, we usually start monitoring around 18 to 20 weeks, and we may monitor every week. And it's quite useful and gives reliable results up to 35 weeks. So this is a flow chart. So just showing how we manage on the basis of MCA-PSV. So once the mother has reached a critical titer, or there's a previous history of affected baby, we start doing MCA-PSV from as early as 18 to 20 weeks we can start. If the value anytime crosses more than 1.5 moms and the gestational age is less than 35, we plan for cordocentesis, take the fetal sample, do the hemoglobin. If the baby is anemic, transfuse in the same sitting. So it is done with all the preparation for intrauterine transfusion. If the MCA-PSV is less than 1.5 mom, we keep monitoring sequentially till the baby reaches term and deliver at 37 weeks. If the gestational age is more than 35, the MCA-PSV trend is normal, then we continue like I said. But if the MCA-PSV increases, then beyond 35 weeks, we would rather deliver preterm and manage the baby in the nursery, because we don't resort to intrauterine transfusion after 34 weeks because the procedure also has its inherent risk of fetal loss. So intrauterine transfusion we plan when we think the baby has anemia, that is if there is hydrops or the MCA-PSV is more than 1.5. You can do intrauterine transfusions as early as 18 weeks, and the last usually we do at 34 weeks. And the routes could be intraperitoneal or intravascular. For us, 100% of the transfusions we do intravascular, and we prefer the route by the umbilical cord. An umbilical vein is targeted. And usually the umbilical vein at the cord insertion is targeted because it is quite stable and easy to puncture. We avoid the umbilical artery because if you puncture the artery, there is risk of spasm and fetal bradycardia. And free floating loops are the last resort because it is very difficult to puncture here. Other site is intrahepatic part of the umbilical vein because it is less chance of fetal bradycardia because there is no artery which can be punctured, and it's easier to do that. So the aim is to raise the hematocrit to around 45 to 50%. But in severely anemic hydropic fetuses or very small fetuses, we usually try to correct anemia over 2-3 transfusions. We do not overload the baby with too much of blood in first sitting. And the amount to be transfused depends on the fetal hematocrit, the hematocrit of the blood we're using, and the desired hematocrit that we want. So there are formulas to calculate, or there are these tables which has a transfusion coefficient. So we can calculate this volume to be transfused based on these formulas. So before we plan intrauterine transfusion, we take consent, explain to the patient the need for the procedure, the risk of the procedures. We need to have a good team, ultrasound machine. We do an ultrasound to localize where we are going to access which part of the cord. We should have facility to do blood group immediately in the OT, and the blood should be ready for transfusion. And we should, after the procedure and during the procedure, we do fetal monitoring. If the baby is viable, for us, if it is beyond 26 weeks, we give steroid cover, and we do the procedure in close proximity to the OT. So in case of any distress, we may deliver the baby by emergency cesarean. We also need the facility. So we need a close support of our neonatology friends. We also need the support of our blood bank people because we need O negative blood cross-match with the mother, because we cross-match for any other antibodies also, because she may have some minor antibodies to other minor antigens. So we cross-match the blood with the mother's blood. The blood used is CMV negative, irradiated, leukodepleted, and centrifuged to a hematocrit of 70 to 80%, so that a small volume can increase the hematocrit nicely, and it is usually fresh blood. So what we routinely paralyze the fetus by giving vancomycin or vacuronium into the fetal thigh or directly into the umbilical cord, and then we enter the cord with a quick stab. Initially, we take the blood sample and do a quick hematocrit, and accordingly, depending on the hematocrit, we calculate the amount of blood to be transfused and start the transfusion at the rate of 5 to 10 ml per minute. And we again take a post-transfusion hematocrit because that will help us decide when to do the next transfusion. And then after the procedure, we monitor the baby, put the baby on continuous CTG till the fetal movements return, because we give muscle relaxant for paralysis. So this is just a small video showing the procedure. So once we have got all our, we usually use a spinal needle of 20 gauge weight for doing the intrauterine transfusion. We get the blood and everything ready. And then what we do, we give a intramuscular injection into the fetal thigh. So you can see there's a needle tip into the fetal thigh, giving pancuronium or vacuronium to paralyze the baby. Because if the baby moves when you're doing the procedure, the needle may get dislodged and you may sort of damage the cord. So we localize the cord, and then we enter the maternal abdomen, uterus through the because it is the anterior cord through the placenta. The needle with a quick jab enters the cord. So we take the initial 1 ml for hematocrit and then start transfusion depending on the hemoglobin levels. And you can see the blood flowing freely into the loop. So you can do it even in a posterior loop of the cord, you can do it. You can, it is almost like a free loop. So it takes a little quick jab to enter, and you may have to, try 1 or twice to get into it. Similarly, you can do it in the free loop, or you can do it in the intrahepatic part of the umbilical vein. So here you can see the needle coming through into the liver, into the intrahepatic part of the vein. After taking the sample, then you transfuse. You can see the turbulence here, which is the blood transfusing. So post-transfusion, we have to monitor the baby for fetal well-being, growth, like we do for any other pregnancy. Then also we have to decide when to do the next transfusion. So for that, we usually look at the rate of decline of hemoglobin at the rate of 0.4, 0.3, 0.2 gram per deciliter after first, second, and third transfusion. So depending on the post-transfusion hematocrit, we see how long at this fall-off rate, when the hemoglobin will become, or hematocrit will become less than 30%, we plan the transfusion accordingly. MCA-PSV is not very accurate for predicting anemia for the second or third transfusion, and mostly we do the last transfusion around 34 to 35 weeks. Intrauterine transfusion is the most successful of fetal therapy, with survival rates as high as 90% for non-hydropic fetuses and 80% to 90% for hydropic fetuses. And we also have our data with very good results of over 90% survival in these babies. Complications can occur like PPROM, cord hematoma, bradycardia during procedure, may require emergency cesarean section. You may even have fetal death, neonatal deaths because of the complication of the procedure. So whenever you're doing a procedure, there is a 3% risk of a complication and 1 to 2% risk of losing the baby for every procedure you do. And our rates are also comparable to that published in the literature. And to avoid the complication, we should avoid free loop, we should avoid arterial puncture, and we should use fetal paralysis. So this is one of our papers we published regarding our outcome. So I think the neonatal outcome will be talked about in the next talk, but there are short-term problems which have to be taken care of. So baby will require NICU care like heart-failure, anemia, thrombocytopenia. These babies also have late anemia and require top-up transfusions. Generally, the neurodevelopmental outcome is good. So normal in almost 95% of the babies on follow-up. But the recent studies are coming which are showing some concern regarding the babies who have received transfusion, that they may be at a higher risk of having cardiovascular problems when they grow up. But this we have to see. These are just reports coming in. We also have patients who come to us who have had 5, 6, 7 losses, who have had hydrops at 24 weeks, 23 weeks. So how do we manage these babies? These women in next pregnancy, when they've had very early onset severe anemia in previous pregnancies. So one option is IVIG, which can be given to the mother from 12 to 13 weeks onwards, and it binds or neutralizes the antibodies in the maternal circulation. So it decreases the hemolysis in the baby. And in this study, they showed that it may delay transfusion by almost 3 weeks. So in very severe cases, in patients who have had losses at very early gestation, we give IVIG, but it is not given as a routine. There was another study in which we had given IVIG with intrauterine transfusion, and we found that it reduced the rate of fall of hematocrit compared to only intrauterine transfusion. And in desperate situations, we may have to ask the mother to go for a gestational carrier who is not isoimmunized or use donor sperm from RHD negative. Sometimes we have resorted to this also when women are really fed up after multiple losses. So to conclude, RH isoimmunization is very much preventable. And I think our aim should be this. And if by chance or if this fails, then the second step should be treatment of fetal anemia with intrauterine transfusion. Timely referral is very important so that these pregnancies can be managed optimally. Thank you. And I would like to acknowledge Professor Deka and Dr. Parna Sharma from the unit, also sharing their data also. Thank you.
Thank you, Vatsala, for such a clear and elaborate, exhaustive presentation on management of RH isoimmunized pregnancies. And every time you take the name of Dr. Deepika Deka, I feel so nostalgic because, I've been so closely associated with her because of her committee and, her support to my committee. So I feel really good, every time we talk about her. And I don't know whether we would be taking questions right now or later on, but just a small question I had that, of course, this was about, fetal transfusion in cases of RH isoimmunization. What about, I'm sure you would be dealing with, the non-immune hydrops as well, where, the fetal anemia is probably because of parvovirus infection or something, which is also a cause of fetal anemia. So in those cases, how is the prognosis, with non-immune hydrops? The problem is that, most of the cases, people, suppose if they refer also, they're cases of non-immune hydrops. And we know that prognosis is not very good, but your experience and the AIMS experience of how many fetal blood transfusions you would have done in cases of non-immune hydrops.
So for non-immune hydrops, if it is parvovirus infection, then usually the outcome is good, because here the anemia is also because of bone marrow suppression, and usually so you just tide over till the effect of the infection is over, till the bone marrow recovers. So prognosis is good. And we have also done transfusions in a couple of cases of placental chorioangioma, which was a cause of fetal anemia, not hydrops, but severe fetal anemia. And there have been a couple of patients in which I have done transfusion. She had baby had would have fetal anemia, hydrops in first pregnancy, then anemia in second pregnancy, transfused, but unfortunately that baby she lost. So I saw her in subsequent pregnancy, gave her 3 transfusions. So it was a case of non-immune hydrops. We sent all the investigations in the first trimester. We did a CBS. We looked at her to rule out hemoglobinopathies, metabolic disorders that we could screen off. But it was a non-immune hydrops. We could not really find a cause. So we're thinking in terms of maybe G6 pyruvate kinase deficiency, but they could not afford the testing. Gave her 3 transfusions. The baby was born, had mild anemia, but didn't require transfusion, and follow-up, the baby was doing well. So sometimes even in unexplained cases, if there is fetal anemia, it's worth transfusing because it definitely is effective. It depends on the cause actually of non-immune hydrops. Because of anemia, we could do. We don't see cases of alpha thalassemia, so there is no experience of transfusing in them. And you can also transfuse in cases of twins.
If one has to refer, to AIMS, then, say of cases of non-immune hydrops, then, it would be rather better, if we know the cause if it's a viral infection or thalassemia or something, rather than if we think it's because of some, congenital anomalies and all that, because I believe that those don't have a good prognosis.
Right.
You refer the patient and then, and the patient and the baby doesn't survive. So would you particularly tell us to what kind of patients with non-immune hydrops we should be referring? I know I'm deviating a bit from the topic because your talk is on RH immunization management, but still
So for non-immune hydrops, you can rule out, what you could do is at least do an ultrasound to rule out congenital anomalies, which could be a cause, cardiac defects, skeletal, other causes. And we would need to screen the mother for infection. So that could be one cause. And then a whole lot of causes like metabolic disorders and hemoglobinopathies, all these. For that, would require invasive testing. And we also need to screen the parents also. But then you cannot if there is a history or depending on, you'll have to take a family history and see what is would be the likely cause. So you may need to do the test for the parents. And if you need to test the baby, you need to do invasive testing. So then it is a good idea to refer.
Thank you so much, Vatsala. And so, Dr. Ranjana, are we moving over to the second talk by Dr. Rakesh or?
Yes.
Okay.
Yeah.
So, Dr. Pragya,
so over to you, Dr. Nikam Prakash Narayan, to introduce the next speaker.
Yeah, thank you very much, Dr. Pragya, for chairing the session so well. And let me start with complimenting Dr. Vatsala for such an exhaustive presentation, which almost intruded to the neonates also. So I think she is in an apex institution, and she is getting the worst cases, I'm sure, and that's why her experience is immense. And definitely, if you see, down the years, because I have an experience of 40 years now, I think everything is, the incidence of this RH discrimination, it has been the number, the incidence is gradually decreasing because of a very good intranatal management and due to the less number of pregnancies which mothers are having. So these two factors are definitely playing a role in the reduction of the worst case type of cases. And still now, I mean, if you are getting such cases, I think it is the apex institution where they go. And I have a proud privilege today to introduce now the next speaker, who has been my student, Dr. Rakesh. He has been my student, and now he is an additional professor in the Department of Pediatrics, IGIMS, and he has about 30 publications. Few of the publications initially we were together, and then of course he has had a lot many publications afterwards also, and has been PI and co-PI in several multicentric research projects, and he has been a speaker, chairperson in several CMEs. Not only that, he has been a very humble, I mean, academician, and he will prove this today by his talk. I'm sure that the subject itself is very, very interesting for any pediatrician. And I must tell you that I have been vice president of this organization, ISOPARB, in the very early years, with, of course, Dr. Usha Sharma. We worked together initially. So over to Dr. Rakesh Kumar for your brilliant talk. Come on.
Thank you, sir. It is really a great honor for me to be introduced by none other than Dr. Nigam Prakash Narayan, who had been my teacher, my mentor, my everything. And I bow my head in front of you, sir.
Thank you.
Sir has been really a great academician, and sir always used to inspire us to do good and be a good student, be a good, now I'm a teacher, so be a good teacher, and to be a good academician as well. And I think among pediatricians of Bihar, sir has got a really a great place among us. And now I really thank to the organizers of today's webinar for giving me opportunity to be a part of this webinar, and have been able to learn so many things by my earlier speaker, Dr. Vassala ma'am. So over to, now I would like to share my screen. Is my screen visible?
Yes, it is.
Yes, yes.
Okay, thank you, ma'am. So RH immunization is one of the leading cause of preventable neuromorbidity and significant neonatal hyperbilirubinemia among the newborns. Ignorance of the pregnant women and their attendants in taking antenatal visits is the main cause behind the late diagnosis of the cases of RH immunization, and thus inviting complications in the form of severe hyperbilirubinemia and kernicterus, and even death in the newborn baby. So there is an urgent need for creating awareness and among the people in general and pregnant women in particular, and educating the healthcare professionals about RH immunization. Early detection and timely and proper management is the only way to avoid complications of RH immunization and having a favorable outcome of the pregnancy. So in a recent study by Bhutani et al., they estimated the worldwide burden of RH hemolytic disease to be about 3.7 lakh cases in a year. India alone contributed to about 56,600 cases in a year. They also estimated that about 1 lakh deaths because of RH hemolytic disease occurs globally, 3/4 of which occurs only in Southeast Asia and sub-Saharan regions. The projected incidence of kernicterus was estimated to be about 28 cases per 1 lakh live births. And there was also seen to be a huge demand-supply gap of anti-RSD that exists in low-middle income countries like India. So the medical science though has advanced a lot, and the obstetricians are really doing great job in providing anti-D prophylaxis to the pregnant woman. But still in developing countries like India, universal anti-D prophylaxis for RH negative mothers is still suboptimal. If we assume that no any form of prophylaxis is used in the RH negative mothers, then it is estimated that 14% of these mothers will develop anti-RH antibodies, and the pregnancy outcome will be about 14% of the newborn will be stillborn, 30% will have severe disease, which can be fatal if not treated properly. 30% will have moderate hyperbilirubinemia and can lead to kernicterus if not treated properly, and the rest of the 40% will remain asymptomatic. So roughly about 50% of RH isoimmunized babies will either die or have severe neuromorbidity if no any form of anti-RHD prophylaxis is used in the susceptible mothers. So it comes to around annual burden of stillborn baby to be around 41,000, neonatal death to be about 90,000, hyperbilirubinemia to be around 97,000, and kernicterus to be around 48,000. So such high will be the burden of disease if RH immunization is not taken care of seriously. RH hemolytic disease of the newborn is regarded as never events and sentinel events. Never event means serious events that can be easily avoidable, which is exactly RH hemolytic disease of newborn is. And sentinel events are those events which are unanticipated events which can lead to death or serious injury to the patient. So RHDN is actually a never event and sentinel event, but unfortunately they are still not very uncommon. So we will go through the pathophysiology of RH immunization with the help of this flowchart in a quick way. So when the RH positive fetal red blood cells comes in the mother circulation through the feto-maternal hemorrhage, IgG antibody is formed against the RH positive fetal RBC. In the first pregnancy, as Dr. Vatsala ma'am has already spoken about, in the first pregnancy, IgM antibody is formed, which we all know do not passes through the placenta, and so the first baby is saved. But in the second pregnancy and subsequent pregnancy with the RH positive fetus, the antibody which is formed is of IgG type, and this IgG antibody crosses the placenta and binds to the RH positive fetal RBCs, and this IgG coated fetal RBC, when travels through the spleen, is trapped there and get hemolyzed there. This causes hemolysis of the blood, leading to fetal anemia, and because of fetal anemia, the fetus wants more and more blood to be formed, and this overworking bone marrow starts releasing the precursor forms of RBC known as erythroblasts, and erythroblasts appear in the peripheral blood smear of the fetus, and this condition is known as erythroblastosis. So this fetal anemia will lead to the fetal hemolysis of the RBCs in fetus will lead to increased bilirubin production. We all know that hemoglobin contains heme, and the heme is converted into biliverdin, and biliverdin is then converted into bilirubin. Also, because of anemia, the fetus wants more and more blood to be formed, and so erythropoiesis starts taking place in places other than the bone marrow, and involving spleen and liver of the fetus and causing hepatosplenomegaly. Also, hydrops fetalis occurs, which is a condition in which fluid accumulates in two or more compartments of the fetus. We will deal with hydrops fetalis later on. If hydrops fetalis is not taken care appropriately with the help of intrauterine transfusion, as Dr. Vatsala ma'am has already told, then it can lead to intrauterine fetal death because of heart failure. After birth of the baby, this increased bilirubin appears as jaundice, but we must also understand that the bilirubin production starts in the fetal life itself, but the baby is not jaundiced at the time of birth, because in the fetal life, bilirubin was taken care of by the maternal placenta. Only later on, the jaundice appears, and if jaundice is not taken care of properly with the help of phototherapy or double volume exchange transfusion, it can lead to kernicterus, which is a deadly complication in which there is irreversible brain damage occurs in the newborn. After even the birth of the baby, the anti-RH antibody is still circulating in the fetal blood, and the hemolysis goes on, causing anemia. Also, in those babies, especially in those babies who are treated with intrauterine transfusion, it has been seen that their marrow is slightly suppressed, and both these ongoing hemolysis and marrow suppression causes late onset anemia in the newborn. So something about hemolytic disease of the fetus and newborn. The spectrum of hemolytic disease varies from mild anemia and simple hyperbilirubinemia to severe hyperbilirubinemia leading to kernicterus and even death of the newborn. Fluid in two or more compartments will be, if there is present, the condition is known as hydrops fetalis. So because of extramedullary hematopoiesis, there is hematopoiesis in the liver, and so liver enlarges, that is hepatomegaly. And because of anemia, the fetus is in a state of heart failure, which leads to hepatic congestion. And so hepatomegaly and hepatic congestion together leads to hepatic dysfunction. And as albumin is made in the liver itself, we all know, so there is less production of albumin in the liver, and it leads to hypoalbuminemia. And the low albumin, because of the low albumin in the fetal blood, the oncotic pressure of the fetal blood decreases, and this leads to extravasation of fluid from the fetal blood, and it goes into the third spaces like pleural cavity, peritoneal cavity, pericardial cavity, subcutaneous tissue, and scalp, causing pleural effusion, ascites, pericardial effusion, subcutaneous edema, and scalp edema. So this is the pathophysiology behind the hydrops fetalis. Also, because of anemia, the oxygen carrying capacity of the fetus decreases, and to increase the oxygen carrying capacity, the fetal heart starts working more and more. So fetal tachycardia develops, and a time comes when even fetal tachycardia, even fetus heart working more and more, but heart is not able to supply oxygen to efficiently to the fetus. So that leads to a state of heart failure, and because of heart failure, there is accumulation of fluid in the lung of the fetus, and it is known as pulmonary edema. Pulmonary edema will lead to respiratory distress, and if not taken care of properly, will lead to respiratory failure. Also, there is decreased platelet production, or if disseminated intravascular coagulation is associated with this condition, then thrombocytopenia will be there, and it will manifest as petechiae purpura and other bleeding manifestations in the fetus, and maybe in the newborn also. ABO incompatibility, we must know that ABO incompatibility in Rh negative pregnancy provides some protection, as in this condition, when the fetal RBC comes in the maternal circulation, it is immediately hemolyzed, and so there is no time for anti-Rh antibody formation. So now something about bilirubin-induced neurological dysfunction and cardiac arrest. Why we are so much worried about hyperbilirubinemia? Because the unconjugated bilirubin can cross the blood-brain barrier and enter into the brain and affect the basal ganglia and the brain stem, causing severe irreversible damage there, which we call it as cardiac arrest. Moderate hyperbilirubinemia results in bilirubin-induced neurological dysfunction, which manifests as poor feeding, poor sucking, hypotonia early, but later on hypertonia, shrill or high-pitched cry, later on developmental delay, cognitive, behavioral, and psychiatric problems in the newborn. Severe hyperbilirubinemia leads to cardiac arrest if not taken care of properly. It is an irreversible condition characterized by hypertonia, opisthotonus, seizures, and later on chorioathetoid cerebral palsy, upward gaze palsy, and sensorineural hearing loss. So coming to the management principles, adequate preparedness for delivery should be there, as it is a very, very high-risk pregnancy, especially in those cases where we found a severe Rh immunization. The pediatrician should understand that he might be needing advanced neonatal resuscitation at the time of delivery, so he should be mentally prepared for that. Prior arrangement of suitable blood is a must, and the blood should be O negative PRBC with AB plasma cross-matched with mother's blood. Immediate processing of cord blood is necessary, and the laboratory personnel should be alerted in advance that we might be needing the reports of lab tests of cord blood in an urgent manner. Assessment of clinical severity should be done by the attending pediatrician, and the future course of action is decided according to the clinical severity. We start intensive phototherapy immediately after birth, and then when the report of cord bilirubin comes, we decide further course of action. At least 2 neonatologists should be present to attend the delivery, as one might need pleural tap or ascitic tap if hydrops baby is delivered. There should be adequate number of skilled staff nurses to attend the delivery, and the resuscitation tray should be well prepared. It should contain ambu bag, different sizes of endotracheal tube, injection adrenaline, injection soda bicarb, and other routine drugs and equipments. Delayed cord clamping should be practiced in uncomplicated cases, as it has been seen by recent studies that delayed cord clamping for 1 minute leads to improved hematocrit of the newborn, and it lessens the requirement for later on transfusions without causing any obvious harm. So we will now go through the postnatal measurement of Rh elimination in a quick way with the help of this flowchart. So with the antenatal setting of mother Rh negative, father Rh positive and indirect Coombs test positive, we do follow the baby with fetal USG and middle cerebral artery peak systolic velocity as already very nicely and explained by Dr. Vasala ma'am, which if suggestive of fetal anemia and or hydrops, then in that case we have to have a prior arrangement of O negative PRBC for double volume exchange transfusion. Advanced neonatal resuscitation should be followed. 2 to 3 trained personnel should be there to attend the delivery, and they should be prepared for abdominal or thoracocentesis. But if the fetal USG and middle cerebral artery peak systolic velocity is not suggestive of fetal anemia or hydrops, then also we have to arrange O negative PRBC for double volume exchange transfusion. Resuscitation as per neonatal resuscitation program is to be done, and delayed cord clamping should be practiced. 1 to 2 ml of cord blood should be immediately sent for lab tests. The tests include hematocrit, cord bilirubin, reticulocyte count, peripheral smear, blood grouping, and cross matching. And the baby is immediately transferred to NICU. In NICU, we start phototherapy immediately, and when we have the report of cord bilirubin, then we decide further course of action according to that. Partial exchange transfusion with O negative PRBC are done in those cases where there is fetal newborn hematocrit, cord hematocrit is less than 30%. We decide about double volume exchange transfusion according to the level of the serum cord bilirubin. Phototherapy is when the baby is on phototherapy, repeats serum bilirubin is done every 6 to 8 hourly, and phototherapy is stopped when 2 consecutive values are below the cutoff. We start iron supplementation at 2 weeks of postnatal age, and follow-up is done for anemia, and PRBC is transfused if clinically indicated. The choice of blood for exchange transfusion is very important, and it has been already covered by earlier speaker, Dr. Rasala ma'am also. If there is no history of intrauterine transfusion, then we can give RH negative packed RBC cross-matched with maternal and infant plasma. But if there is history of intrauterine transfusion, then we have to give O negative PRBC with AB plasma. These tables of choice of blood for exchange transfusion should be there in the NICU for immediate consultation. So now coming something about delayed cord clamping. In a recent study by Sahu et al., which was published in January 2020 in European Journal of Pediatrics, they concluded that delayed cord clamping in isoimmunized infants improved the packed cell volume at 2 hours of life without significantly without causing any adverse effect. In an earlier study by Garbadian et al., which was published in 2016 in Pediatrics, they also concluded that a significant benefit of delayed cord clamping in anemia secondary to Rh illumination resulted in decreased need of postnatal exchange transfusion and without causing any severe hyperbilirubinemia. So delayed cord clamping should be practiced in those cases which are uncomplicated, who are not needing immediate neonatal resuscitation. Now, how to confirm the diagnosis? 1 to 2 ml of cord blood is collected and sent for tests. Blood grouping should be done, and it is usually Rh positive, but can come Rh negative when intrauterine transfusion with O negative blood is done. DCT is usually positive. Peripheral blood smear shows evidence of hemolysis in the form of nucleated RBC, microspherocytosis, and reticulocytosis. Hematocrit will be low, bilirubin will be high, and cross-matching of blood should be done in view of anticipating exchange transfusion or transfusion. So now something about partial exchange transfusion. It is done in those cases in which the cord hematocrit is below 30%, or the features of hydrops or cardiac decompensation is present in the newborn. What it do? It increases hemoglobin without causing volume overload in the newborn. We all know that in newborn, the blood volume per kg is more than the adult blood volume per kg. So if we will straightforward transfuse blood in them, it will cause hypervolemia, and fetal heart, which is already compromised, can land up into heart failure. So in these cases, we prefer partial exchange transfusion. The volume of blood to be used for partial exchange is calculated by this formula, and partial exchange can be done either through the umbilical vein catheterization or through the radial artery vein route. So now coming to double volume exchange transfusion, it is indicated when cord bilirubin is more than or equal to 4.5 to 5 milligram per deciliter, or cord hemoglobin is less than 10 milligram per deciliter, or rate of rise of bilirubin is more than 0.5 milligram per deciliter per hour despite phototherapy. Also, if the bilirubin crosses the exchange threshold as per the American Academy of Pediatrics chart, Miser's chart, NICE guidelines, or BILIAP, volume exchange transfusion is to be done. At any level of bilirubin, if there are features of BIND, that is bilirubin-induced neurological damage, are coming, like poor feeding, the baby is poorly feeding, the baby is having poor sucking, hypotonia is there, the baby's cry is shrill or high-pitched, and bilirubin is any, then it is also an indication for double volume exchange transfusion. The choice of blood, as I have already told, if history of intrauterine transfusion is present, then O negative PRBC. If there is no history of intrauterine transfusion, then Rh negative PRBC cross-matched against mothers and infants' blood suspended in corresponding antibody negative plasma. Volume of blood to be calculated is by the formula 2 into weight in kg into blood volume per kg. Blood volume per kg is determined by Rawlings chart, and which is roughly about 80 ml per kg when the weight of the baby is more than 2 kg, and 90 ml per kg if the weight of the baby is between 1 to 2 kg, and 100 ml per kg if the weight of baby is below 1 kg. Double volume exchange transfusion is an invasive procedure, so all the aseptic precautions is to be taken while doing exchange transfusion. The mortality is less than 0.3%, and morbidities include dislodgement of catheter, thrombosis, infection, acidosis, arrhythmia, fluid and electrolyte imbalance like hypoglycemia and hypocalcemia, and portal hypertension later in life. After exchange, bilirubin is measured every 4 to 8 hourly, as bilirubin may rebound to its 40 to 50% of its previous value due to re-equilibration. In sick anemic neonates, single volume exchange transfusion is done, but single volume exchange transfusion is less effective as it only replaces about 60% of the blood volume, while double volume exchange transfusion replaces about 85 to 90% of the blood volume. Double volume exchange transfusion removes about 90% of the anti-Rh antibody from the fetal circulation, and thus it reduces to much extent the further hemolysis, and it reduces bilirubin to about 50%, so it decreases the bilirubin level to a significant level. Now coming to phototherapy, it is the most safe and most commonly used intervention nowadays, and if done properly, nowadays the use of double volume exchange transfusion has need for double volume exchange transfusion has drastically reduced. Majority of Rh immunized infants can be managed by phototherapy alone. Serum bilirubin above the threshold of phototherapy as per AAP chart or Miser chart, NICE guideline, BILIAP is used to decide for phototherapy. Phototherapy mainly acts by photoisomerization of unconjugated 4-jet 15-jet bilirubin to 4-jet 15E bilirubin, which is then excreted with bile and into the feces. Serum bilirubin is monitored every 4 to 8 hourly, and it is stopped when 2 samples are below the cutoff levels. Also, serum bilirubin monitoring should be continued for at least 24 hours after stopping phototherapy, as because of the continued hemolysis, it may increase. Some of the side effects of phototherapy are loose stools, erythematous rash, and dehydration. This is the AAP nomogram, which is used for as a guideline for phototherapy. We can see there are 3 lines. The upper line is for low risk group, which is used in those cases where the gestational age of the newborn is 38 weeks or more. The middle line is for the middle risk group, which is used in those babies whose gestational age is 38 weeks or more and risk factor is present in them. We will see later on what are the risk factors. And it is also used in those babies whose gestational age is between 35 to 37 weeks. The below line is used in high risk group, and this include those babies who have gestational age 35 to 37 weeks and risk factor is present in them. Risk factors are isoimmune hemolytic anemia, glucose 6-phosphate dehydrogenase deficiency, asphyxia, significant lethargy, temperature instability, sepsis, acidosis, or hypoalbuminemia. Why risk factor is so important? Because if risk factors are present in the baby, then the chances of bilirubin to cross the blood-brain barrier and affect the brain will be very high. So we take lower cutoffs for doing phototherapy or exchange transfusion if risk factor is associated or present in the baby. This chart is for guideline for exchange transfusion. This is also American Academy of Pediatrics chart, nomogram, Meisel's chart, and this NICE guidelines are used for those babies who are less than 35 weeks of gestation. Coming to intravenous immunoglobulin, it was earlier used as an adjunctive therapy for hyperbilirubinemia, but its use has decreased a lot today. Nowadays, it is used when bilirubin level is rising despite intensive phototherapy and the level is below 2 to 3 milligram deciliter below the exchange level. It acts by increasing IgG catabolism, thus lowers the level of IgG, and it blocks the IgG receptor on macrophages and thus prevent the hemolysis to occur. The dose is 0.5 to 1 gram per kg per dose that may be repeated after 12 hours. Recent studies have shown little benefit and we have also stopped using it since last 2 to 3 years. In a recent Cochrane systematic review published in 2018, they concluded that based on their results, they found insufficient confidence in the effect of estimate of benefit of IVIG to make even a early recommendation for IVIG for the management of illumination. They said further studies are needed to confirm it. Follow-up should be done of such babies, RH illuminized babies. The follow-up includes the investigations like the hematocrit, hemoglobin, and the bilirubin. Anemia may manifest after 4 to 6 weeks to 3 months of life. So it is followed with the level of hemoglobin. The anemia can be of hemolytic and or hyporegenerative anemia. Hemolytic is because of the antibody is still present in the fetal blood, in the newborn's blood, and it will be seen as reticulocytosis and microerythrocytosis in the peripheral blood smear. Hyporegenerative anemia, the peripheral blood smear shows low reticulocyte count and macrocytosis. And hyporegenerative anemia is seen especially in those cases who are treated with intrauterine transfusion. Iron supplementation should be started at 2 weeks of age. Some centers advocate the use of recombinant erythropoietin, but it is costly and seen to be associated with retinopathy of prematurity, which is particularly in premature babies. Inspissated bile syndrome is another complication in which we found a mixed type of hyperbilirubinemia, that is direct and indirect, both are present. The cause is not clear, but it gradually recovers by itself. Portal vein thrombosis leading to portal hypertension are seen in those cases who are treated with double volume exchange transfusion by the umbilical vein catheterization, and it is a late complication in the newborn. So thank you a lot for your patient listening. Thank you.
Excellent presentation, Rakesh. I'm proud to have a student like you. Thank you very much.
Thank you, sir.
And I think you can stop sharing and we will discuss a few points. Yeah. So you just stop sharing. Yeah. I think yes, just stop sharing. That's right. Wonderful. So I think you have really had an excellent presentation covering every aspect of the newborn who is affected by this RH isoimmunization. I think I will add only 2 or 3 points. The one is that the ABO incompatibility sometimes prevents, you see, this worst type of outcome, number one.
Sir.
Number 2 is that if you have that 4 and 14 formula, that is, if the cord blood, which has got a bilirubin of more than 4 and a hemoglobin of less than 14, then you are always alarmed. And then you have to repeat it almost on an hourly basis and monitor if it is rising beyond 0.5 milligram per hour, then you have to go for the double volume exchange. And you have to start off with, of course, phototherapy. The third point, which actually I wanted to tell you, that if you are doing a double volume exchange with the push-pull technique, sometimes if they are hemodynamically too unstable or if they are having a lot of hydrops, then it is better than you have another flow from the umbilical vein, and then you have, you see, constantly, if you are pulling out and pushing out almost constantly, that is the best way to prevent from the further disasters. So these are the 3 points which I wanted to just add. And I think it was a wonderful presentation by you, and of course by Vatsala as well. So I think any questions, if you have in the chat box, I'll just check. I don't think there is any question because you had such a wonderful presentation. And if there are any questions, I think we can still answer. And if not, I think... Yes, Dr.
Question
Vatsala.
for Dr. Vatsala.
Carry on.
Okay.
Yes?
Is
Vatsala, are you
just
there? Yes.
yeah.
There is one question. In a multi-gravida patient, when we don't know about the immunization status in previous pregnancy, when should we go for ICT? Whether it can be done in first trimester? You have already answered in the chat box.
Yeah, I was just answering yes.
But please.
No, you should. If she is Rh negative, and you should do the ICT at this first visit itself, because if she is ICT is positive, then we need to know the titers, and if the titers are like more than 160, then she should be referred to a center where she can be monitored for fetal anemia. We should not delay unnecessarily.
Okay. There's another question. There's another question that IUT details, give the IUT details. How do you calculate amount of intrauterine transfusion and which blood group?
So we use O negative blood group, which is cross-matched with the mother's blood, because we look for other antibodies in the mother also if she has antibody to any antigens, and we cross-match so she doesn't get sensitized if there are any antigens in the blood that we're transfusing, because that blood can also go into her circulation. So it has to be cross-matched with the mother's. And for the amount of blood to be transfused as shown in the slide, there's a formula which takes into account the fetal hematocrit, the desired hematocrit, which we usually target at 45 to 50%, hematocrit of the blood that is being transfused, which is around 75 to 80%, and the fetal-placental volume, which can be calculated according to the gestational age and weight. So, and there is another way of calculating is a table in which you see like how much of blood you want to, how much hematocrit you want to increase. Suppose a fetal hematocrit is 20 and you want to make it 40. So you want a 20% rise multiplied by the weight in grams, and then there is a coefficient. You multiply it by that, you get the volume. So it's an easier way to calculate. So we have this formula in our OT. So as soon as we know the hematocrit, we calculate and start transfusing.
Yes. Thank you, Vatsala. There's another question. How will you manage a post-dated case of Rh negative pregnancy? Dr. Anamika wants to know.
If you have a post-dated, you should actually, if you are monitoring the patient, don't allow her to go beyond 40 weeks, because the longer the pregnancy continues, we know that the fetal-maternal hemorrhage is occurring all the time. So there is exposure. If she's got post-dated, you should induce and deliver.
Okay.
And then after delivery, depending on the blood group of the baby, give her the anti-T.
There's one more question. What are the benefits with 2 doses?
Actually, whether you give 1 dose of 300 micrograms at 28 weeks or 2 doses of 100 micrograms at 28 and 32 weeks, there is no difference. Both are equally effective. Okay. So except for the RCOG, which follows 2 doses, the ACOG guideline, and we also follow a single dose, 300 microgram.
Okay. Thank you.
Vatsala, can I ask you a question?
Yes,
Amita, I would like to ask Vatsala.
Yes, madam.
When we are having, say, patients who have had multiple fetal losses and they have presented to us, should we send them for pre-pregnancy counseling to your unit?
Ma'am, definitely they can come, but the thing is they're going to travel from a distance for pre-pregnancy counseling, but definitely we have to explain to them that whatever gestation the fetus was affected is likely to be affected earlier and more severely in the subsequent pregnancy. So what is important is as soon as they are pregnant, maybe around 16, 18 weeks, you should refer them so we can start monitoring them for fetal anemia and transfuse as and when required.
So you wouldn't like them say, like recently I have had someone who's, as you say, has had 3 losses. First one is okay. After that, she has had 3 losses. And the last one was at 16 weeks. So when would I send her to you in the next pregnancy?
And the 16 weeks loss was because of RH. It was a hydrops or
Yes,
something.
yes, all as you are saying, the
Right.
titers were high. We had done ICT and everything, and the titers were quite high. And on ultra, she presented at 16 weeks. And on ultrasound, there was already fetal demise, high ICT titers, everything was there. So,
And
what
we
would you
usually,
suggest I do with her?
so usually, Madam Ma'am, we'll have to look, see if it is actually because of fetal anemia or some other cause, because a hydrops, that is a severest form of fetal anemia, usually will not occur before 20 weeks. It's
No, no,
usually
she
after.
wasn't hydra, fetal demise. She had already, there was no fetal heart, anything. I didn't say hydrops.
So, ma'am, so that's the thing. Maybe it is not related to RH, but otherwise they have to come early. And cases which have very early losses, we can give IVIG from 12 weeks so that the effect of whatever like fetal anemia is delayed. Because if the pregnancy, suppose the baby is affected at 20 weeks, 22 weeks, she's had drops, and next pregnancy she's likely to be affected more early, and it is very difficult to do any transfusion at even 20 weeks. So it's better that we give IVIG from 12 weeks. That will delay the onset of severe anemia by a couple of weeks.
When she comes next time, say I have called her at 2 months pregnancy, should I send her to you at that time or at 10 weeks?
Once you document fetal viability, you can do a scan at 11 weeks and see
that is
everything
why
is
I called
okay,
her.
and then you can send. Yes.
Okay, thank you.
Thank you, ma'am.
Thank you, Vatsala, for answering all the questions. Now I hand over the session to both the chairpersons, Dr. Nigam Prakash sir and Dr.
Yeah.
Pragya, for concluding remarks.
Yeah, thank you. I think the whole, organization needs a real commendation because this was a very well organized, webinar. And we had none other than Dr. Vatsala Dadwal, and she has been such a wonderful speaker, along with Dr. Rakesh Kumar, who is the additional professor here in IGIMS. I think both of them given real, presentation today. And I think the way Dr. Vatsala answered the questions, that shows that she is at the helm of affairs. Thank you very much. And
Thank you, sir.
yeah, definitely. And definitely the whole organization and especially the conveners. I'm very proud of you both, Amita and Ranjana. Such a nice presentation. On Dr. Usha Sharma, still you are having so much of experience and you have such difficult cases to put forward. Thank you. So I think, and Dr. Pragya, of course, she has been a very active member of the ISOPARB. Of course, along with all the ISOPARB faculties here, which are present here. So I think it was a wonderful session today, and I really compliment you all. Thank you very much.
Yes, Dr. Pragya, please.
Yeah, thank you to you also, Dr. Narayan, for having chaired the session so well, and never saying no to whenever either ISOPAB or Patna and Gynae invites you. That's very nice. And even in the program on Alive and Thrive, actually I was admitted at AIMS, that day. But I was actually I could listen, to because I had COVID and I was admitted in the hospital, but I was. Yeah, and I was listening to your program, on that Alive and Thrive Day in the big early August. Yeah.
Wonderful, wonderful. Thank you, Pragya, for your academic interest even at that point of time. Thank you. Thank you very much.
Well, thank you all. It's very true that this session was very fascinating and insightful for me, and I have learned a lot. So both the speakers were excellent, and both the chairpersons presented their inputs brilliantly. So we quickly move to the second session. Can I have the CV of Dr. Rita Sinha and other chairpersons? Okay. It's my honor to invite chairperson of second session. May I invite Dr. Rita Sinha Madam? She is ex-professor, Department of OB/GY, PMCH, Patna. Currently, she is professor at Narayan Medical College, Sasaram. Master Trainer and IGNOU. She has been examiner of undergraduate, postgraduate, She is part of our Patna chapter and she has contributed chapters in many books and her area of interest is high-risk pregnancy. Madam, I welcome you to this virtual platform of ISOPAR webinar. Our
Thank you,
lecture
Amita.
is
Thank you, Amita. क्या है देखो ना इसका साउंड नहीं आ रहा.
Hello.
हाँ, thank you, Amita. हाँ,
Mohan Das, madam. Yes.
नहीं हो गया
Dr.
दूसरा.
Shobna Mohan Das, madam, is from Kerala and she's chief consultant, gynecologist and laparoscopic surgeon there. She's also vice president of Indian Menopause Society. Madam is past secretary, general website committee and chairperson, chair of IMS. She has vast experience of Indian Menopause Society and she is very knowledgeable about the menopause. But she's also a very known figure of Foxy, and she's vice president of IMA Thrissur, president IMA Women's Wing, and she's past scientific chair, journal editor talks. I think this is from Tamil Nadu OBGY Society, no? She's madam is past scientific committee chairperson of journal editor of Tamil Nadu OBGY Society, and she has authored 2 textbooks in gynecology and invited speaker at more than 20 venues. I also welcome you, madam, to this virtual platform of ISOPA webinar. Now I hand over the session to both of you.
Thank you, Amita. Good evening, everybody. I am thankful to the organizer, Dr. Usha Sharma, President of ISOPAR, Dr. Meena Saman, Secretary General, and Dr. Amita and Dr. Ranjana, my dear, for giving me the opportunity for this wonderful session where VWAC has revisited. For this, we have Vijay Lakshmi Sheshadri. She is senior consultant of Sudaram Medical Foundation, Chennai. She is vice president of OGSSI, chairperson of research committee, IMS. She is member of quiz committee, Foxy, member of quiz committee, IMS. She is past South Zone coordinator of Safe Motherhood Committee, Foxy, past Chennai chapter secretary, organizing chairperson of ISOPAR conference held at 2017 at Chennai. She contributed to Foxy book or quiz in 2019. Her special interest is high risk obstetrics and midlife health. I am handing over the mic to the next chairperson, Dr. Shobna Mohan Das.
Thank you, Dr. Rita. Now, my great friend, Dr. Vijay Lakshmi Sheshadri, in spite of personal loss, she's come to talk on a very passionate topic of hers, that's obstetrics, and she has been in a teaching institute for so long. I'm sure she must have been screaming at her juniors for doing this and not doing that. And always when a woman comes with a 2-line positive after a previous cesarean, always I ask, so now what? Doctor, can you give me a normal delivery next time? And when she comes at term, all that goes off. Doctor, no, I can't go through the whole trial again. Take the baby out somehow now. The pace just changes from what it was in first trimester to what it happens in last trimester. So now I'm sure Vijay Lakshmi will come and tell us how we can give a smile. I always tell them, if you come with pain at home, I will give you a normal delivery. But if you don't come with pain from home, to induce you and give you 2-3 days of labor pain and then I will deliver you, I am going to put my neck in trouble. So Dr. Vijay Lakshmi, you will definitely teach us how to give a smiling face even after induction in a previous cesarean, or you will have two thoughts about that. Let's see what you're going to talk.
Am I audible and am I visible?
Yes, Dr. Vijay, you
very
are.
well.
Okay. So I'm really thankful to Meena, Ranjana, I mean all my friends there, and who have really passionately invited me here. Amita for coordinating the whole program, And of course, it's an honor to be here in the presence of Ushadi and Madam Kamal Bakshi and of course Nigam sir. Now, ISOPAR, whenever it decides, I know they decide practical topics, and some I feel are outdated if you think that way. And vaginal birth after cesarean, as Shobna also put out, whether I'm screaming in the labor room, what happened. And I think there is still a necessity to look into. And as Dr. Rita said, uh, revisiting vaginal birth after cesarean, so that itself implies that probably we have reduced the numbers of the vaginal birth which we can do after the cesarean section. Now, it is definitely passing away technology, or we can say our skills are fading off, but it is also lots of other factors which are coming up here. And let's just go a quick run through what is exactly we are looking into whenever we are talking about a VBAC. Now, so we come to a very important point. Is once a cesarean always a cesarean? And this question goes in the mind of all the obstetricians as well as the patients. And the trial of labor after the cesarean, I will not say it's a dying art, but definitely slowly the numbers are coming down, and it's because of several reasons. So we'll just look into what are the considerations that we are thinking about whenever we are discussing VBAC. The major three questions which need to be answered are: is it possible, is it feasible, and is it agreeable? We know there is a suspense in every obstetric case which goes through the antenatal period and then delivers. Lots of considerations for us through the antenatal period, and then also have a delivery, and even at the full dilatation, even at zero station, whatever, we still can switch over to cesarean for some reason. So is a cesarean to be followed by a vaginal birth with all the different angles which are associated with them? So these three important questions: is it possible, feasible, and agreeable? We know the possibility hangs on in the even in the minds of the obstetrician, as well as the surroundings which are there to really scare us or threaten us. No, no, what are you talking about? Is there a cesarean? No, she had her first cesarean. In fact, quite often nowadays when we get a patient and when we try to take an obstetric history and ask her, how was your first delivery? Oh, it was just a cesarean. I mean, it has become so casual with them that it looks as if doing a normal delivery is not normal. And so this kind of an impression has to go, even from the point of view of the patient's perception. Most of them do want it, but as they come closer to the term pregnancy, are we really trying to come into an equilibrium or an equation with the patient's choices? And how much of this decision making of doing a vaginal birth after cesarean, giving it a trial, is that we can shoulder and we can give it to the patient as well. So there is always a compound decision making along with the patient from the point of view of making it successful. Let's just, for a glance, look at these two case scenarios. A 30-year-old gravida 2, para 1, no issues in the previous antenatal period. The past pregnancy ended up in a cesarean section done as an emergency for a fetal distress. 3 years back, and a live boy baby, doing well, no issues, and the intra and post-operative was also uneventful. And now patient presents to us again after 3 years in pregnancy. And as we move ahead, with her pregnancy through the antenatal course. At 36 weeks, the scan is also normal and there are no comorbidities. And now is the decision, what do we do? Have we made up our mind regarding her the methodology for delivery? Let us look at another case scenario. A 28-year-old third gravida, P1L1, one abortion, had the previous cesarean section done for a premature rupture of membranes. In breech presentation, we all know breaches are not uncommon in preterms, and 35 weeks, and ended up in a girl with 1.9 kg, was in an ICU but then recovered very well. No issues. Patient has forgotten the whole thing. She has gone through a cesarean. She now has a live baby, and that is all that matters to her. 4 years later, she comes to us with another pregnancy, and at this juncture, at 37 weeks, she from 28-30 weeks, she has been diagnosed of GDM. But now when we are reviewing, she is well under control, and her estimated weight now is 3.2 kg, and she has some more time to go ahead for the term, and we don't know whether it will end up in a macrosomic baby or not, or the growth curves will be okay because of her GDM. So when we think of these two case scenarios, these are not just the two representative samples, but day in and day out, we are all here, we know, even especially the senior madams who are also here, we all know every day, every time we practice, we have umpteen of these cases presenting in a different way with different presentations, depending on their history and the past history. But if they have a cesarean section done in the past, the entire perspective has to be different. So every day, what are we thinking about whenever we come across a cesarean section followed by a pregnancy going on? We have to make ourselves very clear with lots of things moving around in our minds. What are the indications? What are the contraindications? How much are we prepared? What are our limitations to approach whenever we are deciding on vaginal delivery? And of course, what is it when we talk about a vaginal delivery versus an elective cesarean section?
आपका डॉगी कैसा है?
Somebody is talking. Can somebody?
Milo.
Antenatal count.
उनसे कुछ नई चीज गंदा नाम कैसे रख लिया? गंदा क्या है? अच्छा नहीं है ना.
And then the antenatal counseling and the decision making that goes on. And I said the decision making is always a joint decision making from the obstetrician side. And how much of guarantee can you give them? And spontaneous and versus induced, are we prepared to induce these pregnancies? How do we monitor pre-operate, pre-labor, post-labor, intra-labor, and how well are we prepared for the complications? And ultimately, with all this background and all this knowledge, are we okay that it will succeed or it will lead to an emergency LSCS? So whenever we talk of a pregnancy with a previous cesarean section, all these questions must run through our minds and they must be answered at least within our mind as to how are we going to manage each point which is here. Now we can't say the indications for VBSC because after all, any pregnancy is an indication for vaginal delivery, and vaginal delivery after a cesarean, the indication is only the pregnancy with a previous cesarean scar. So I'm not going to talk about under the heading of indication. But what is most important is we have to remember what is a contraindication where we don't contemplate on the vaginal birth after cesarean. Previous uterine rupture for very obvious reasons. Any history of uterine dehiscence, I mean, it need not be a scar earlier. Even without the scar, if there has been a history, or suppose this is a third cesarean section and there has been a problem in the scar earlier, whatever, we cannot allow or think about a vaginal delivery now. And of course, as an obstetrician, we know all these factors of severe oligomenosis, malpresentations, a big baby, a contracted pelvis, a cephalopelvic disproportion, and of course the complicated uterine scars, meaning the J scars, the U scars, the V scars, whatever has been given in the previous cesarean, or even if there have been some myomectomies or there have been some other septal resections, all those kinds of complicated uterine scars will definitely have problem even if you are going to give a trial of labor. The uterine anomalies, for that matter, if we have a septate uterus, we have an arcuate uterus, anyway, they have gone through the previous labor, but have they gone through a direct elective cesarean or have gone through a trial of labor and have gone into the elective cesarean in the previous pregnancy, it also matters what we are going to discuss in this pregnancy. Placenta previa and the placenta accreta syndrome, we know anytime we talk about PPH, anytime we talk about the placenta, anytime we talk about the cesarean section, we cannot get this placenta previa and the placenta accreta syndrome out of our minds. And as they say, the cesarean sections are increasing in numbers, and so also the placenta accreta syndrome increasing, because obviously the scar area provides a nidus for the implantation to happen, and we do have the accreta, increta, and percreta problems. So we need to fear about this. But in this pregnancy, with the previous cesarean scar, if in this pregnancy even we have a slight idea that could it be a placenta accreta syndrome, then we need to be very, very careful about obviously giving a problem. Even in cesarean, we have problems with the accreta. Obviously, accreta syndrome is going to give us enough trouble if you are going to even deliver her vaginally. So these are all almost the indications where, or the states where we don't even contemplate on a vaginal delivery following a cesarean section. We must always remember, do no harm, which is our motto in our oath. So we know that we cannot allow the patient into any kind of discussion in places where she does not have a place for a vaginal delivery. Because we have to, some places we have to give a little bit of hearing to the patient's choices. Sometimes we have to overrule, and of course we must know how to counsel and go ahead safely, meaning safety of the patient and the baby. Now, there is something called as BBAC prediction score. I'm not really in a mood to go through all the details of the score. If somebody is interested on an individual basis, I can always send them all these scores. Of course, they are available, but on the net as well. But anyway, I can send them if they are interested. But actually, why I'm not going into all these details is, are we really going to follow these scores and then put them? Now it's a fashion. It has become a fashion that we talk about scores and do. But actually, all these scores are based on certain basic ideologies, basic things, and that is common to all of them. It is just a question of filling up those columns and telling them either a low score, mid score, high score, or tell them less than 4, less than 5, less than 7, or tell them 70%, 80%, 90%. It's just readjustment of those factors. But actually, all of them mean the same. All of them just give us a predictive value. And therefore, because this itself may take about 10 to 15 minutes, and therefore, we will go into the usual what are the non-suitability. As I said, as much as we can think of the contraindications, we have to be very careful about the non-suitability, meaning we cannot subject these patients into we can subject them for a vaginal delivery, but then these are the conditions where you are not likely to succeed at all, and you may ultimately end up into cesarean. So let us just go through a few topics here. The postdatism, we know postdatism is always scary. You are always very comfortable when the patient delivers before the date close to term. And now we know 39 to 40 weeks, we are very, very comfortable. But beyond that, because of the issues of the induction, monitoring, obviously, VBAC, postdatism becomes a non-suitable factor. Obesity is as much an issue anywhere, wherever we have high BMIs, and therefore we are not even thinking about that. And we know it is not just the patient size as such. We know they relate the obesity to the accumulation of lot of fat and soft tissue thickness in the pelvic cavity, decreasing the room, and then giving us trouble during vaginal deliveries. Not that the obese people don't deliver normally, but we are talking about the VBAC and trying to see which are the conditions which may give us a lot of trouble. Age beyond 40 years, and of course, we know the last childbirth less than 1 year is definitely not suitable. And although LCB less than 1 year looks very, very short interval, but believe me, there are many patients who do conceive within 2 months, and then they say, oh, having conceived, I will continue. And there is still a large gap between the understanding of the patient's risks in that early conception or a lesser interval, and the contraception usage and the termination services. So when they don't go hand in hand and the patient gets into an early pregnancy to follow the previous scar, again, it is going to be a little non-suitable for her. The low pre-labor Bishop score is very, very important in VBAC, where we have to start from the beginning. The cervix is thick, it is not yielded, and she has not gone into the real labor. So how long do we wait, and how comfortable we are in allowing her to go for VBAC is the question. We all know the lower uterine segment, myometrial thickness and thinness are deciding factors. And now with more radiological help coming through by the way of either an ultrasound, if we can get to know, or even MRI, because even for we know the placenta accreta syndrome, ultrasound is not a reliable tool, and we have to depend on MRI. So the same way, if the myometrial thickness can be taken well, if possible by a very good sonologist with the ultrasound, or if required wherever we think there is a lot of thinning by an MRI, then that also can tell us that we are not going to decide this patient for a VBAC. And the critical value they say is 0.6 to 2 mm. Now, again, we are talking of a likelihood of success. These are all again going to be the same overlapping conditions, the possibilities, the indications, the contraindications, the non-favorable factors, and now comes the likelihood of success. When the BMI is less than 30, when the age is less than 40, the gestational age less than 40, and of course, estimated fetal weight less than 4. I won't even take it to 4 kg. I would rather be uncomfortable even at 3.7, 3.5. But they say till 4 kgs is also okay, and VBACs are quite successful. Obviously, vertex presentation, and when she presents with the engaged presenting part, we are very happy. And of course, a high admission Bishop score, that is what I meant. We know she's going to progress very well, and it is very important to assess that Bishop score at admission if we are planning for the vaginal delivery. The spontaneous onset of labor is one thing which is definitely a favorable factor, and a past vaginal delivery. Suppose she had, this is her third gravida, previous cesarean, and she had one past vaginal delivery, that is itself a big certification, because we all know it's a tried pelvis, and therefore the likelihood of the success of the vaginal birth after the scar is going to be high. And therefore, in all the scoring systems that I mentioned, the vaginal delivery, past vaginal delivery, is an important history where they give a maximum score to give us the likelihood of success. Now, the same way how we say likelihood of success, we must also be worried about the likelihood of failure. So, a birth weight, expected weight, suppose this is based on her past cesarean section. If the past cesarean section had the delivery of a baby which was less than the expected weight in the present pregnancy, obviously we know that it is not a fully tried pelvis, and therefore we might end up into issues, and that is what signifies the birth weight. The failed induction of labor, where that cesarean was the deciding factor, because of the failure on the induction of labor, is also not going to give you much success in this pregnancy. The failed instrumental delivery, we have tried either a failed vacuum, a failed forceps, and then taken up for cesarean in the past, is also going to be not very favorable. Now, the dystocia, if the previous cesarean indication was a dystocia at 8 centimeters or beyond, again, now we will have chances for failure. The prolonged second stage, and then she doesn't deliver, and then we take her late in the prolonged second stage, is also going to be, this is all about the past history. The whole issue here is how much of these informations are we able to get from the patients. She has a discharge summary which just says cesarean section done, some indication, very pertinent or not very pertinent, whatever, and ultimately patient is happy, the obstetrician is happy, everything has gone well. But in the discharge summary, we do not get too many details on the suturing techniques, the healing which had happened, how many layers the suturing cesarean section was done, and that's why this particular data which we get about the past cesarean section may not be very informative, or may not add to our decision making much. Although we know we should know, and some, of course, some patients are very smart, they are able to tell, but quite often I have seen discharges where the discharge summaries say cesarean section done in the usual way, and that is the end of the story. The baby is there, live, all those timings and dates. So, how much of these informations can we get dependably about the previous cesarean section is, of course, a big question mark. Now, this is again just a small route map that you should start thinking about when you're managing a pregnant patient with a previous cesarean section. You must start thinking about as early as the late first trimester, or even 12 to 16 weeks. You review the records as much as possible. If she is the same person who is coming to the same obstetrician, and if we are really storing the messages in the computers, and definitely with all the details, you may be able to make lots of information from here. And then, of course, with the anomaly scan, again, placental localization is important, but we know apparent placental migration happens, and therefore, this is not the time to think about a low placenta, but this is the time to think that we need to contemplate about it as we move ahead in the pregnancy, and decision again can be made at 32 weeks, 36 weeks, reassessing the placenta, and be guarded about it. So that will give us a clue whether we can really decide in favor of a trial of labor. you keep waiting, again assess, again decide. So this process should continue from the time of her 12 weeks or 14 weeks, so that you sound her enough that you are wanting to give. You can read her mind, she can read your mind. And that kind of a dialogue, that kind of an individual decision making is very, very important. Because again, like most of the obstetric cases, we know one size doesn't fit all. The same way, in this particular this, we have to have the cooperation of the patient as well. And therefore, the whole process of antenatal checkups and communications, and whether you want it, patient wants it, whether can be given, whether cannot be given, whether the decision needs to be altered as we move ahead, or whether the decision can be left based on the circumstances. So all these decision makings will come at every stage. And the elective cesarean section is not the rule for all the patients who go in for cesarean section. So if that is there, then we won't be discussing this topic at all. But we definitely know that this is slightly reducing as the ages are going. Even for in my own practice, I used to deliver, do VBACs more than what I'm trying to do now, and for several reasons. And of course, I know the next generation. In fact, the other day I was asking one of the PGs, and she said, "Oh, is it? Do we do? Do we need to do?" Those kinds of questions are coming in the next generation. And I think it is our responsibility to introduce this VBAC into the minds of the next generation, and not taking it absolute terms that the cesarean has to be followed by a cesarean. And I'm really happy that ISOPARB has decided this topic today. And definitely it is a visit or a revisit, but then we need to keep this in mind all the time. And if it was not a virtual platform, and if it was a direct on-stage platform, perhaps I could have even asked the audience how many still support VBAC, or how many in their own practice. Thank you, Meena. I can see your hand. And how many in the delegate list or the faculty list think that why take all the trouble of going through this exercise, just do off the another cesarean and get out of it. But that is not the situation which we should promote, and it is our very, very big responsibility as senior obstetricians and growing up obstetricians that we evolve this thought into the minds of the coming generations. Sorry. Now, it's the after having discussed all the possibilities, the likelihoods, the indications, contraindications, and what all you are thinking, and suitabilities, non-suitabilities, once we decide with repeated counseling and these, which I said, counseling forms and very important hallmark of the management, like any other case, but then here all the more, because when you do direct cesareans, you think it is there, patient might not be very happy, because sometimes it is very important for the patient to go through one experience of a normal labor. We don't know whether the previous cesarean was a direct cesarean, an elective cesarean, or was with the trial of labor. And quite often we have to get the information. And sometimes, with due respects to everyone, there is a little bit of discrepancy between what is written in the indication, in the discharge summaries, and what the patient tells us. So we obviously will believe and support our own colleagues. We should believe the discharge summaries. But what happens is sometimes that leaves a little bit of dissatisfaction as far as the patient is concerned, and she feels, no, last time I didn't really go through labor, and this time I want a normal labor tried. And this is a willing patient, and if all the other conditions look fine, we should be able to mold this idea into a VBAC. So counseling at every stage, as I even showed earlier, is very, very important. And of course, documentation is the important thing at every stage. Whether you are doing an antenatal, you're trying to come to a conclusion whether you can give a trial or you need not give a trial. That again has to be documented. And if the patient is willing and she says, I would go through it, that also is important. Because any complication, any problem, she would say, I never wanted it. And you were insisting that you need to give, and see what is happening now. Labor room settings are very important. We cannot blame any obstetricians for having taken a decision in favor of a cesarean, especially in the previous car, because it's very important to have a proper labor room settings with all the facilities, and the mindset has to be there, but at the same time, able to switch over to emergency cesarean, able to switch over and avail the facilities of the anesthetist, the theatre, after a failure or a complication is again very important. So obviously we cannot run away from this fact that individual room settings have to be acknowledged by the obstetrician herself. Of course, a senior obstetrician, if we are juniors, we have to call our seniors or at least keep them standby. If we are seniors, we can always take the help of some more hands, because again, this is suddenly it becomes a great teamwork when the unpredicted or the eventuality comes after we give a trial of labor. Continuous fetal monitoring is very important, and when she goes into active labor, the trained personnel is again very important. You cannot manage anything in obstetrics all alone. The greater the help from your juniors, from the surrounding people, from the nursing staff and everybody, that is the time when we can really think about it. A close monitoring is an essential part of any labor, more so here. You cannot allow the patient to be, you cannot have 6 patients laboring at the same time and 1 person with VBAC into trial of labor. That is not indicated, and 1-to-1 monitoring is the essence where you can catch up the problems early. So all these are prerequisites. So we have to run through in our mind whether we would be able to manage all this and then go ahead giving her a trial of labor. What do? We have decided, we have counseled, we have made up our mind, the patient comes at 39 weeks in spontaneous labor. We have told her we would be able to give her trial of labor based on lots of other conditions which we have discussed. The question is, do all the patients go into spontaneous labor? Do all the patients deliver at 39 weeks? We know that is the best scenario we are expecting, but that may not happen. The epidural analgesia is not to be worried about. It is okay to give epidural analgesia if the need is there, but we have to also worry that there is an association, although some studies say it is not so, but there are lots of studies which also say that the prolonged second stage or uterine inertia comes on with epidural. How far it is true, it depends on individual practice. Quite often abroad, epidural analgesia is almost a routine, whereas in VBAC, are we comfortable giving them the epidural analgesia? Because increased need will definitely, if she keeps on demanding more, you have to suspect dehiscence at some stage. The electronic fetal, as I said, the fetal monitoring, the clinical monitoring, the cervicometric progress cannot be compromised at all. Now, there are certain controversies. How do you decide which gestational age is good? Do we wait till 39? Do we go at 40? Can we wait beyond 41? Of course, the best time is 39 to 40. And if she goes into labor earlier, 38, 37 is okay as far as VBAC is concerned. The planned VBAC is the rule. The elective repeat cesarean section versus the emergency cesarean section has to be always kept in mind. We all know when a planned VBAC goes into a failure and we convert her into an emergency cesarean section, that is the worst scenario for the patient, for us, and for the cesarean section as such. And of course, if there is some kind of a dehiscence or rupture, it's also the worst scenario for the neonatal morbidity and mortality. Now, the labor induction is definitely, although people have said, there are some studies, I went through the literature where they have said, okay, they have given prostaglandins, but personally I think, and perhaps the seniors will also accept, that amniotomy is all that is okay for induction. Foley's catheter or some mechanical device is okay, but that apart, the inductions are not safe. Augmentation by oxytocin have been done in several cases, but then again, it increases the mortality or rupture by 2 to 3 times, and that has to be kept in mind. Now, the uterine dehiscence and rupture are the most scary things which we are worried. And whenever you try to counsel on this to the patient, obviously patient herself might say, oh no, I don't want anything more. Just give me a live baby and a live my mother and baby should go home safe. There is no need. So, but then those groups where you are trying to give a BPAC, obviously we need to detail out on the fetal compromise and the possible demise, the uterine dehiscence and the possible rupture. And generally these would be a warning signals. We all know as practitioners an abnormal cardiotocogram in labor, severe abdominal pain which she complains, which is usually a constant pain, a kind of a tetanic pain, and that is a little scary. The change in the abdominal contour, the moment the uterus ruptures, we can understand the baby is, whether a little bit of part of the baby comes or something happens, and by the time you decide and shift to theatre, the whole contour has changed. Maternal vitals, without any suspicion or doubt, we know will always mark the shock stage or the possibility of a rupture. We can depend on the temperature, pulse, blood pressure. The scar tenderness, which we do monitor even during antenatal period. We know there are many patients who would say about the tenderness, and some you will have to distinguish from the skin stretch tenderness and the real suprapubic tenderness which happens. So it is not the cutaneous scar, but it is a suprapubic tenderness in the uterus, which is again alarming. The loss of station of the presenting part may come the moment there is some dehiscence or rupture. Of course, we know abnormal vaginal bleed, but there have been some cases where the vaginal bleeding has not presented and still dehiscence has happened. Of course, to extend it further, hematuria can always happen. The vaginal birth, VBAC, has ended up in uterine rupture. Many a times they say the maximum happens at 4 to 5 centimeters of dilatation. 90% happens in labor, while 80% happens in second stage of labor. Just imagine at second stage of labor, you are all there to deliver and you diagnose the dehiscence or rupture. It is really, really catastrophic. The 8% identified even post-vaginal delivery. Sometimes we do not know, and definitely we all know as practitioners that we cannot put our hand into the uterine cavity just to test for the intactness of the scar. That is not allowed. But of course, the ultrasound can give us a clue, but again it is difficult with the bleeding and the clots therein. So sometimes they have found, just see, the scar dehiscence of 48% goes asymptomatic, and that has to be kept in mind. From suspected rupture, if you are able to deliver the baby within 7 to 18 minutes, they have said, I don't know whether the neonatologist will agree to it, that maybe your non-hypoxic fetus can come out. Otherwise, beyond this, it is risky for the baby anyway. The risk in the planned VBAC, the rupture, has been 0.2 to 0.5%, whereas in the elective cesarean section, the risk is only 0.02%, and probably most of us are able to have the repeat cesarean without any ruptures in our entire obstetric history. The VBAC score, as I said, with all those parameters, Bishop score, age, BMI, indication of previous cesarean, And the most important, history of previous vaginal delivery is very, very important. So risks and benefits. Back to an intrauterine demise, if you are going to wait beyond 39 weeks, they do not understand why particularly we are talking of an intrauterine demise beyond 39 weeks in BBACs, but that is an association they have found. And they say it's always better to deliver at 39 or before 39. Delivery-related perinatal deaths have been 0.04%, hypoxic ischemic encephalopathy 0.08% for the neonat, the maternal death 0.004%, and of course we know transient tachypnea of the newborn is lesser in the vaginal deliveries compared to the cesarean sections. It's 2 to 3% here, and the uterine dehiscence 0.1% if successful, 2.3% if failed. It's not difficult to understand these statistics, though we say almost 70 to 75% do succeed into a BPAC and definitely demand our attention. Blood transfusion of 1% in an elective repeat cesarean, reduced prolapse, possibility of a ruptured uterus is much less. The transient tachypnea is much, much higher, and therefore the respiratory morbidity maybe we could avoid a little bit with steroids or passing the 39 weeks of gestation. But then again, that is not the criteria that we can give steroids and then go ahead with elective repeat cesarean section. HIE is 0.01%, and of course we know the morbidity and mortality attached to the surgical procedures, the adhesions for the future for her abdominal procedures, she is going to land up into greater morbidity, and of course the risk of the placenta greta syndrome, which I have discussed even earlier. Tubectomy could be a co-condition, co-surgery, which we do, but of course that should not form an incentive for giving an elective repeat cesarean instead of a trial of labor. So I'm coming to the end of my talk, where I'm going to just go through a small sum up assessment. So back to those questions, the primary questions of possibility, feasibility, and agreeability. Possible, depending on the conditions; feasible, depending on our facilities; agreeable for both the mother, the patient, and to the obstetrician. And of course, we need to involve the neonatologist as well. Counseling at every stage, first trimester, second trimester, third trimester, involve the patient in every decision making that passes our mind. In labor, of course, a greater thing and very, very important is the consent and the documentation, because we know consent could be verbal or written, but very important to include all the complications of the labor in contents. And patient has to sign, her witness has to sign, and you must definitely include the husband in decision making. And all these are very important, because we know when we shift from the labor room to the theatre, we hardly have time to go in for a detailed discussion, and go ahead with the witness calling and explaining. So you explain everything so that you rush into the theatre. And there is no excuse for us to say that we did not have time to explain and we just rushed because we wanted to say. So it is very important to do all this even before we give a trial of labor. The antenatal, pre-labor, labor documentations, very important. The course at every stage, at every step is very important. And of course, managing and the all the kind of what we are doing is very, very important. Documentation is the one which has become a most essential thing now. Of course, keep worrying about the legal tangles. Don't get scared. Don't get worried. But at the same time, don't be superwoman or super obstetrician and think we can manage everything. The legal tangles are always there and we need to worry about them. So the best is perhaps then avoid the first cesarean as much as possible. Let us not take all the indications very lightly and go ahead with the cesarean section. It's very important to decide very prudently with all our will and wish whether we definitely need to do a first cesarean. Of course, we always keep hovering around three important overlapping things to strike a balance between the cesarean section rate, the maternal mortality and morbidity, and the fetal mortality and morbidity. Of course, I've taken the help of all these guidelines to form this discussion. Any questions, I'll be happy. But I know it's a very, very clinical topic. And even at the end of this, I'd be very happy to get answers from people to say, no, no, what you're talking is nothing practical in this era. Or we should say, no, we have to get back to the idea of mooting this VBAC into the previous cesarean sections. I'm really happy to have been talking about this because it's a very important topic that as obstetricians we have a great responsibility. Thank you very much. I really thank profusely for the entire organizing committee and all my friends, as I said, and all the seniors, and of course to the delegates who have logged in. Thank you very much.
Dr. Vijay Lakshmi Sheshadri for your excellent presentation covering every aspect of VBAC. After your speech, vaginal birth after cesarean section is an option for several women. If pregnancy is very healthy, good monitoring, lower transfer uterine scar, and well taken inclusion criteria is the success of VBAC, and it can be successfully done. Thank you.
Thank you. Thank you, ma'am. Thanks.
Shobna ma'am, Shobna ma'am, are you there? Kindly come in.
Shobna madam, not to be seen.
Shobna has gone because some urgent work.
Okay.
Okay.
Madam, Usha madam. I'd like to have your opinion,
ma'am. Ma'am, unmute please. Usha ma'am, unmute please.
Yes, I've unmuted myself. Vijaya Lakshmi, it was a brilliant presentation. But I have a question for you because you have presented it so well. In your practice, once you have satisfied all the criteria that she is a suitable candidate for VBAC, how long do you give her in active stage of labor?
Madam, as such, I think we do not form a criteria, but over the experience I can tell you. But because now even in normal labors, we are not saying 2 hours, 3 hours, full dilatation, first stage of labor. I think all those cutoffs have been increased to give a little lesser cesarean section rate. And we say, don't say 3 centimeters active line. I think all those have got shifted. Partograms and everything has been shifted to the right, the active line and alert line and everything. So I would say that definitely as the labor goes on and if the full dilatation, obviously I'm not going, because already anyway she's a second gravida or third gravida, and even it also depends, like if in previous cesarean she did not go into labor at all, she has been taken for an elective indication, this time she will be behaving like a preemie as far as the pelvic things are concerned in labor. So we will have to give a little more room if at all we are trying. But what I would suggest perhaps or think is that if you are deciding that all factors are favorable, you are sitting on your patient, you are monitoring closely, I think we can go ahead giving as much as possible the full trial. There is no point in telling her, I'll give you a trial of labor, and then within half an hour or 1 hour or 2 hours, you say, oh, that's enough, you have not progressed. That is not
No, I don't mean
from
1 2 hours. Yes,
yes
upper limit of your trial.
Yes, ma'am. From my own experience, I will say perhaps if in a year we do about say 5 or 6 suppose we take it as 5 or 6 cesarean VBACs, then in those, in an average, the second stage of labor has never been more than 10 minutes or 15 minutes, because it becomes very difficult. Either she will push or she will have problems, and then you try to switch over. But the first stage of labor, from the say 3 centimeter dilatation to the full dilatation, we have waited even for maybe 6 hours, 5 hours and all. I mean, as long as the fetal monitoring have gone well.
All the
But definitely, madam, what is your opinion? Say, because I think
I give
that
8
we become
hours.
jittery as well.
No. I give 8 hours minimum.
I have
Once
not
I'm
probably
satisfied,
gone beyond 6 hours. But yes, if you are giving with a full heart and soul, I think as long as the
But your
complications
ladies in second stage are really quick. Ours sometimes they take more than half an hour or maybe even an hour. Because as you know, I'm sure you are fully versed that second stage has 2 stages.
Yes, ma'am.
The first, yeah.
First again, latent
As you
stage of the
say,
second
yeah,
stage.
yes. And then in 10 minutes, you must be really lucky.
That's
Dr.
what I said, madam. The question is like we have started slightly relaxing over the timings, isn't it, madam? We used to be very worried with the stages of labor. Now I think 6 centimeters, 7 centimeters. After that also we wait enough because we say the labor, active labor has still not started. So I think our thinking has also gone very favorably, I would say, towards a little more weight with the patient. But
Dr.
again,
yes.
Yes,
Dr. Sheshadri, I have done in many cases.
Yes, madam, sure you would have.
Yes. So partogram should be maintained in this case.
Yes, ma'am.
Also, and if it is left side of the line, of action line, we should give the time. But if it is on the right side, we do it quickly. And also, at the second stage of labor, if everything is okay, there is no suprapubic pain, and then we can assisted vaginal delivery can be done by the ventules. Also, we can take some help from the ventules. So
Yes,
I
ma'am.
have done in so many cases. Partogram should be maintained, and we do as the partogram says. Thank you.
But I think, madam, they have revised these partogram drawings also.
Yes.
Because
Now
as long, yes, partogram should be maintained. But as you say, previously it was a centimeter an hour for the multip. But now even if it is 1.5 centimeters per hour, we accept it because the guidelines have changed. Yeah.
Tobna ma'am, please unmute. We want your comments, please.
She disappeared in between. Unmute, Shobna.
Shobna is not here, but it is well organized webinar and it is very informative. And the subject is also.
I had to disappear in between thoda. I'm sorry, Vijay Lakshmi, but it was an
No problem,
hour-long
no
talk,
problem.
you know. I was not expecting it so long, so I had, I had another engagement about personal engagement there. But it was very, very long, and I don't know how much you must have studied to get this together. My God. So it's
no, in
a lot
fact,
of effort taken.
No, I think it was not so tough. The reason being, it was more practical. See, this particular topic is more practical. So, as you make slides, you know what you have gone through and what is coming on. Of course,
yeah, actually, it's a learning experience and it's a lot of hard work. Just like all Viji's meetings, she takes a lot of efforts.
Thank you. Thank you, Shobna.
Thank you, Vijay.
Thank you, ma'am, for your wonderful deliberation. It was really very, very vast.
I would be happy if somebody,
Madam,
get this idea into people who can join and say, yes, we want to do VBSc.
Madam, we learned a lot and you had specific points for us to carry home. And there is only one question, I think, and that is related to RH isoimmunization, but anyone can answer it. Is anti-D advisable for primary patient who has been diagnosed RH negative during antenatal? So that is the question, I think.
Madam will say, Usha madam.
Yes, this RH immunization you have just said. When we heard her lecture, doctor, the girl from AIMS, Vatsala, she has very clearly said that antenatal you can give them, and postnatal, if the baby is RH neg, then you do not need to give the postnatal dose. But antenatal one, unless by this prenatal testing you know the blood group of the baby, you have to give the anti-D.
Even in primary cases?
Yeah, even in primary, protect karne ke liye, because the hemorrhages keep occurring.
Yes, ma'am.
So
yes,
this,
and And another question is, in corona period, should VBAC be allowed in COVID positive cases?
I think that is
I like what corona or no corona, it's all the same. No, I don't know.
No, we will not
Are
do.
we not doing vaginal deliveries? We are not doing.
We will not do.
And there are comments also for you, ma'am. An excellent revisit through VBAC. Well done. Thank you, ma'am. That is a comment from Dr. Shanti. So, ma'am, it was really a wonderful talk. And I must thank both the chairpersons, Rita Sinha, ma'am, and who has come with us despite her angioplasty being done 2-3 days back. And ma'am, I thank you really from the core of my heart to as you are with us today. And also to Dr. Shobna ma'am, who has readily agreed and conducted the session.
I'm sorry,
so well.
I just went little bit in between.
No problem, Shobna. We know you, everything. No issues.
And thank you, Vijay Lakshmi ma'am. And now it's time to call upon our dynamic Secretary General, Dr. Meena Samant, whose academic pursuits have resulted in the series of webinars organized by ISOPARB, giving us opportunity to meet again and again. And as far as and as far as her CV is concerned,
no, thank you.
Okay, okay. Everyone knows her. So, Meena, Dr. Meena Samant, please propose a vote of thanks.
Okay, now it's my pleasant task to propose a vote of thanks, and let me tell you, it comes from the core of my heart. I begin by thanking all the delegates who've logged in today for this important session on high-risk pregnancy, and my special thanks to our chief guest, our guest of honor, all rolled into one, Professor Kamal Bakshi, Madam. Thank you, Madam, for gracing this occasion. Your presence, your blessings makes this webinar even more special. She has been a great clinician, a great teacher, and she's, inspired a generation of doctors and still continues to do so. My thanks. I'm thanking on behalf of ISOPARB, so I would say my president is included here, but I'd still go on to thank her once again, being there from the start till the end and inspiring all our office bearers to be in the same spirit as her. My thanks to the chairpersons, the expert comments, Dr. Nigam Prakash Narayan sir, who had to leave for another webinar, my friend Dr. Pragya Mishra. We know how, she's really been involved with RH negative and fetal medicine, and her presence today was definitely needed. Dr. Professor Rita Sinha, Madam, thank you, ma'am. I did not know you were not so well, but yes, past president of ISOPAR Patna, always encouraging us. Then we have Dr. Shobna, Madam. Thank you, ma'am, for joining. And we know her as the first member from Kerala. And first, but not of course, now with her, others are following. Thank you, ma'am, for being here today. And what to say for all our speakers of today, Dr. Vatsala Dedwal, for sharing her thoughts, her expertise and experience of RH immunized pregnancy. It was a really wonderful lecture. Then Dr. Rajesh Kumar from our own AIMS, IGIMS Patna, he giving his inputs about the babies management. Thank you, Dr. Rajesh. Then, of course, I'm so proud of myself having included asking Dr. Vijay Lakshmi Sheshadri for this topic. And she went, it was a fabulous lecture, bringing out so many points about this. And I just want to add, Madam, because you know what happens in the institute. Once a lady in labor, previous section, there's a madam, there's one patient, previous section, she's in labor, ma'am, we are rushing for cesarean. So that is what has come to. So I think that is something we need to change. if a person previous cesarean is in labor, that's the best scenario we could have to give her a vaginal birth. So that is one thing. And another, only last week, I had a patient of previous two cesarean section. There have been previous pasts where previous two have come into labor, and before we could rush her to the OT, they delivered on their own. But last time was a previous two. This was an IUD. The estimated baby size was less than 2 kgs, and she was not in labor. So we gave her Mifigest to ripen her cervix and followed it by Foley's catheter, and she went into spontaneous. Thereafter, we did not need to give her oxytocin. She went into labor and had a smooth vaginal delivery, no problems there. So I mean, actually, we need to, to reorganize our thought process. Things have changed because the cesarean section has become so rampant. But then this is something which has been going on, and we need to re-look into it. Thank you, ma'am, for such a wonderful lecture. So
Thank
I
you,
also
Meena.
thank this Bharat Serum, then Session and his team for this, giving us this very good platform. And they are quite so organized in doing all this thing, the mock drills and all that. So it makes it quite comfortable to work with them. Thank you. And I'm sure I must have missed some names, but even if I have, please excuse me for that. And once again, I thank each and every one of you. A very vibrant audience asking so many questions. So that is quite encouraging for these speakers who've done a lot of homework and come and they're giving their time. So thank you, audience. Thank you all once again. And good night. I think we can call it a
Thanks.
day now.
Yes, yes.
Yeah.